Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, AMOGS Emergency Obstetrics Committee with UPCOG, Lucknow, Varanasi, Firozabad and Greater Noida OBGYN societies. It's my proud privilege to introduce the coordinator of today's webinar, Dr. Nutan Upadhyaya ma'am. Ma'am is the FOXY committee member study on female breast diseases 2020 to 2024, president of Saharanpur OBGYN Society 2020-21, scientific secretary of SOX 2003. I welcome you, ma'am, and I hand over the session for further proceedings.
Thank you, Saiti. A very, very warm welcome, regards to all the seniors and the stalwarts of UPCOG. We will start. This is our fourth in the series, which is going on in combination with AMOGS. Dr. Sneha Buhair has been doing a very wonderful job. And we are now joining in with Lucknow, Varanasi, Greater Noida, and Firozabad societies. So a very, very good evening. Yaha north mein to thodi barish ho, so we are having a slightly pleasant. The temperature has dropped slightly. So let's with this good note, let's start our academic session. I would like to invite Dr. Bharti Maheshwari.
You will first we will have the inauguration video and then I will do the welcome. Let us have the prayers first.
Okay.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
So with this virtual Up Deepo Bhava, I would now like to Dr. Sneha Buhair, the person behind all these series, to introduce our further the convener and the further coordinator. Dr. Sneha Buhair, please take the proceedings further.
Yes. I would take the welcome address later. I think few words from my dear friend Dr. Bharti Maheshwari, who has been instrumental in this collaboration to bring AMOGS and UPCOG together. As you know, Bharti is a very dear friend, and of course, the secretary of UPCOG. She was a chairperson with us for the FOXY MTP committee, and of course, the organizing secretary of many of the UPCOG conferences. So with this, I invite you, Bharti, for the welcome.
Yes, thank you, Dr. Sneha. So first of all, namaskar and greetings from UPCOG as well as AMOGS. And we all know that we are now familiar with both office bearer, UPCOG and AMOGS. And I can see here the president of AMOGS, Dr. Kiran Kurkoti sir, and the president of our UPCOG madam couldn't join due to she's out of India. And first of all, I pay regards to our patrons of UPCOG, Dr. Usha Sharma madam, though she is not here, but due to some family reasons. Then Dr. Chandravati madam, she is here. We are very fortunate that madam, your positive vibes to all of us and always your inspiration. And then of course, our immediate Meera Agnihotri madam, I am not able to see her. And then our immediate past president, Dr. Anuradha Khanna madam, she is always very enthusiastic and always timid pigeons. Madam, your prestigious present is always very important to us. Then we have, of course, chief guest, Dr. Tang sir couldn't, I'm not able to see. Probably he will join soon. And then, of course, from the we have our guest of honors as well as our special guest So we can see our all our four societies president as well as secretary, Dr. S.P. Jaiswal, Madam President, our special guest today, and of course Dr. Preeti. We can see Dr. Manju Shukla, Madam, and our prestigious speakers also, and very important topic that is designed beautifully by Dr. Sneha. I know her for last so many years. Of course, we all know her, and for last 3 webinars that is done with UPCOG, we are having very important topics, and as well as today also. So now to Dr. Sneha Bhuar for further introducing about the topics and saying something about vision. And today Dr. Anita also has joined with Dr. Nutan Upadhyay. Nutan is doing, wonderful work with us, so much of interest. I am so proud of you, Nutan. And Dr. Anita, you have also joined today for the successful running of this webinars with the AMOGS and UPCOG. So this is really very good signals that we all are working together for the women health, and we can meet at least 1-2 months in a once time together in this platform. So now to Dr. Sneha.
Yes. Thank you so much, Dr. Bharati, for the wonderful warm welcome from your side. A very good evening to all of you once again from my side. At the outset, my respect and regards to all the 3 patrons of UPCOG, Madam Padma Shri Usha Sharma, Madam Meera Agnihotri ji, and Madam Chandravati ji. My respect and regards to our President Foxy, Dr. Jaideep Tank will be joining in few minutes. And of course, the guest of honor, Madam Chandravati ji and Madam Anuradha Khanna. The special guest for today, Madam Manju Shukla, and our dear friend Preeti Kumar. Friends, we have today decided the topics. Of course, I welcome my dear friend Bharati Maheshwari also, and our esteemed speakers, Dr. Charmila Ayyaho, who will be speaking on the obstructed labor, and Professor and Head Dr. Anju Agrawal, who will help us in going through the instrumental delivery. Myself, Dr. Sneha Bhuar, the hardcore obstetrician with 32 years of experience, I shall sail you through all the labor room emergencies. Dr. Sangeeta Rai, the President of Varanasi, Shrita Avasti, the Secretary, and the entire team of Varanasi, I welcome you all. Dr. S.P. Jaiswal, Madam, who is the expert for today's panel discussion. Dr. Deepa Kapoor, the Vice President of Lucknow. Dr. Nidhi Jori, Secretary of Lucknow. Dr. Renu Gupta, the President, and Dr. Shuchi Jain from Team Firozabad. Dr. Sadhna Jaiswal, the President of Greater Noida, and Dr. Samta Gupta, and of course, experts and chairpersons, Dr. Vanita Maske, Dr. Namita Bajpai, Dr. Poonam Agrawal, Dr. Apeksha Vishnoi, Dr. Indulata Sahu, Dr. Shuchi Jain, and Dr. Mamta Singh as esteemed panelist. Our dear friends, Dr. Nutan Upadhyay and Anita as coordinators who have done all the hard work. I welcome all of you on behalf of Dr. Kiran Kurtakoti, the President of AMOGS, Dr. Bipin Pandit, Secretary, and Dr. Rajendra Singh Pardesi, the immediate past President, Dr. Madhuri Mendra, the Treasurer, and of course, Dr. Parag Biniwale, our dear friend, who is the National Coordinator for AMOGS. So I welcome all of you. And with this, I invite the President of AMOGS first, just to express his warm welcome. So over to you. Do we have Dr. Jaideep Tank join? Has Sir joined?
Not yet, ma'am.
Okay, so he has messaged me that he will join in 5 minutes. So by the time we will have Dr. Kiran Kurtakoti, as his welcome address from your side.
Thank you, Dr. Sneha. My greetings and pranams to Dr. Kirti Dubey, the President of UPCOG, Dr. Bharati, my close friend and the Secretary of UPCOG. Today's guest of honor, Chandravati Madam. We had a lovely time with Madam when she was in Pune at the STAR conference. Dr. Anuradha Khanna, pranam to you also. And of course, I will not forget Dr. Meera Agnihotri Madam. She's not there, but again, pranam to her also. And I dare not forget Dr. Preeti, Dr. Anita, Dr. Manju Shukla, when I am on this particular dais. Preeti, it's okay, fine. A very warm welcome on behalf of AMOGS, and thank you, UP, because you have been getting along with AMOGS not only in this particular webinar, but since the last 2 to 3 years or so. So it's really a lovely feeling. I can see Dr. Charmila. Charmila, I don't know how many awards you have behind you. I don't know how many awards we can have, those many awards behind us. The day will come shortly. And my friend Parag, of course, who is the national coordinator of AMOGS. So thank you over and all. Sneha, you are organizing so many wonderful webinars. And in case we have this particular archives of all the webinars, we can write a textbook, or you can create a textbook or a virtual textbook wherein, postgraduate students can learn something from that. So I would request Shield, Sahiti from Shield. She's also webinar hopping along with me. So Shield, of course, can compile all these webinars with so much information and knowledge. Yesterday, I had the pleasure of listening to Dr. Jayam Kannan also. So fantastic work that you are doing, and really a big appreciation. I have been observing you right from my undergraduate and postgraduate days, since you were together at VC Medical College, Pune, and you're doing a fantastic job, and we hope, wish and pray that all your dreams come true. So also all the dreams of whoever is here, including Dr. Preeti ji, they also come true. Anita ji. Okay, Preeti, baad mein milna. Okay. Thank you over and all. Thank you so much. And once again, greetings and pranams to all the elders from AMOGS. And thank you so much. Be with AMOGS always. Thank you so much.
Thank you so much, Dr. Kiran, for our friendship, and of course your support as AMOGS president means a lot to me. Thank you so much. I think Dr. Jaideep Thang sir is yet to join, so by the time we will have blessings from Madam Chandravati ji, whom I don't dare to introduce Madam. Of course, everybody knows Madam so very well, and Madam's the CV, though it is such a short CV, I'm sure it runs in pages, but I would just say she is the patron of UPCOG, and your blessings matter much to all of us, Madam, and we are eager to listen to your precious words. Over to you, Madam.
Thank you, Sneha. Thank you. I must really appreciate that for you, Sneha. You bring so many people together and give us a chance to talk to each other and meet each other. Scientific sessions are wonderful. Whatever you organize every time, I've come to your webinars, and I've really appreciated those topics and subjects you have chosen for these webinars. And you have really collected stalwarts for your topics today. Before I forget, I must not forget to wish you luck, wish you Preeti luck, Anita luck, Dr. Chavila luck. So my blessings and luck, wishing luck is there. I wish that your topic today's dealing for day-to-day obstetric is a very, very, very important. I think it is wonderful for the normal people to learn all day-to-day things rather than going to the bookish knowledge when we talk onto the subjects. Hi Parag, it's nice to see you there. And I'm sorry I cannot see Jaideep yet. I think shortly you will be joining. But my wishes are there that your today's webinar becomes very, very successful, and all the participants learn a lot from today's subject. Thank you.
Thank you so much, Madam. And let us have Madam Anuradha Khanna's blessings. And of course, Madam is the immediate past president of UPCOG, of course, the ex-president of Varanasi Obstetrics Society, revered teacher, and of course, teacher of teachers, I would say. Such a highly decorated CV, Madam, you have. We are really eager to listen to your precious words. Over to you, Madam Anuradha Khanna.
Thank you so much, Dr. Sneha, and my blessings also along with your so much nice programs you have arranged for all of us, and it's going on so well. I've got a lot of blessings for you, and since we are having our mentor, Madam Chandravati, with us, so she is a recognition for me. I'm telling you, whenever I see her, I watch her, I just become more younger. Seeing her working, I feel I'm still very young. And I've seen that all the good ideas are there. Just now seen Dr. Parag Binewale, Bharti is working so hard, Manjuji is there, and Dr. Kiran has welcomed her. You along with Dutan is doing a very excellent job. Preeti is there. My lot of blessings to Preeti also. Anita, I think you are already blessed, and all the speakers, Sanju, and everyone is going to deliver a good academic session. And the moderator, you, and along with your so knowledgeable panelists. So I'm really eager to listen because this obstetrical emergency is a nightmare for me still. And whenever I go see, call anything, then I just take oath of the God, because whatever I'm going to do, we all are going to do as a teamwork is with the guidance of God. Whatever we are having the knowledge, that is okay. But as Madam Chandravati said, that immediate practical aspects are the most important thing. So I think what we are going to listen, what we are going to have panel discussion, this will be all with practical along with the knowledge behind. Thank you so much for my invitation. And to whom I have taken not names, please let me say thanks to all of you and all my best wishes to all of you. Dr. Sneha ji, thank you.
Thank you so much, madam, for your blessings. And of course, always it means a lot when we have you here. Thank you so much, madam. And Jadip sir is just right in time here. A very warm welcome to you, sir. I'm sure this is a busy slide, and this slide is not sufficient to introduce you, sir. Definitely, all of you know, and you are such a respected personality with highly decorated CV. The President Foxy, Deputy Secretary, Asia Oceania Federation of Obsgynae, immediate past chair of International Federation of Obstetrics and Gynecology Committee for Safe Abortion, past chair Publication and Newsletter Committee, AOFOG, and past chair Reproductive Endocrinology and Infertility Committee of AOFOG. So many posts and positions, sir. But we are really blessed to have you, and over to you for your precious words of guidance. Jaideep, sir. I think, hello. Jaideep, sir, I think we can't hear your voice. The device, I think.
Sir, please unmute, yeah.
No, he is unmuted. I think sir joined.
No, he's not unmuted. I can see red bar on her sound
No.
icon. I have seen.
Jaideep sir, we can't hear you, sir.
Saiti, can you help him, please?
Sir has already been unmuted, but I don't know.
Yeah, but then whether he has joined.
I think sir need to check his system volume, ma'am. System volume. Sometimes if it is low, it will be.
And whether he joined it without computer audio.
Yeah. Sir is joining again, I think.
Yeah. We wait for a moment. Yes.
Yeah, sir is there.
Now connecting to audio. Now I can see.
Yeah,
Yes,
sorry. Is that better?
Yes.
Good evening, sir.
Okay.
Good evening.
Good evening. Sorry. First of all, let me apologize for being late for this. I was a little tied up with a patient who I was delivering. She took a little longer than I thought, that she would take to deliver. Let me first begin by thanking Sneha for inviting me for this.
Sir, please unmute yourself, sir.
Okay, sorry, I don't know why this is happening. Maybe they want me to finish early and get on with the scientific program. Am I audible now?
Yes.
Sir.
In fact, we are waiting for your precious words, sir. Please
Yeah,
go.
sorry. So I understand that this is a collaboration between the AMOGS and the UPCOG, and it's always a delight to be a part of anything that is organized by these two wonderful organizations. And I must thank and acknowledge the office bearers of these organizations, Dr. Kiran Koti, the president, Pardesi sir, immediate past president, Dr. Kirti Dubey, president of UPCOG, Anuradha madam, the immediate past president. And I must also apologize for missing the UPCOG this time, which was, I think, held in Bareilly. Unfortunately, it was the same day as the Foxy Managing Committee, and that's why I could not make it.
Yes.
Yeah. Again, I want to congratulate and thank Sneha for organizing this, but I also want to thank her for one other very important reason, and that is, Sneha, that you have organized this. So I've got to see Dr. Chandravati Madam after a very long time. It is always such a pleasure and privilege to see Madam. Madam, I hope you are well, and we are looking forward to seeing you again. Let me also acknowledge Dr. Anuradha Khanna. She was so kind just now when I had visited Varanasi, and she's always been so helpful. And of course, one of our youngest members in Foxy, Dr. Manju Shukla Madam. Uh,
True.
and of course, the
सही है
always
एकदम.
always enthusiastic and hardworking Dr. Preeti Kumar. I know that some of you are standing for elections, and I would like to wish all the very best. I see elections not only as something to achieve a post, but also an indicator of interest in that organization. And the fact that these elections are there, they are so hard fought, and so many deserving candidates are there, speaks to me greatly about Foxy's future. So, all the very best to all of you. And you put together such a fantastic program with Charmila, Dr. Anju Agarwal as speakers, and then a panel discussion which will be moderated by Sneha. And so many excellent chairpersons, Dr. Sangeeta Rai, Dr. Nidhi, Dr. Ishita, Dr. Deepa Kapoor, Dr. Renu, Dr. Samta, Dr. Jaiswar as the expert, and such wonderful panelists. Let me also thank and congratulate the convener, Dr. Bharti, the coordinator, Dr. Nuttan and Dr. Anita, and all the panelists, Dr. Sahu, Dr. Suchi Jain, Dr. Mamta Singh, Dr. Vanita, Dr. Namita, Dr. Poonam, and the office bearers of all the societies who are participating. I know that some of them are part of the faculty, but I'm looking forward to working with all of them in the GATES project, which will hopefully be rolled out in the next couple of months, where Uttar Pradesh is our focus state, and we hope to work in upwards of 15 districts there. So thank you very much again, Sneha. Many congratulations. I know that Sneha has always raised the bar whenever she's worked. I remember her tenure as chairperson of breastfeeding committee with great memories, and Sneha wishing everyone here all the very best. Thank you.
Thank you. Thanks,
Thank
sir,
you,
from
sir. Thank you so
UPCOG.
much.
Yeah.
Thank you so much, sir, for your blessings and, of course, such precious words of guidance. Now, may I welcome Madam Manju Shukla as special guest for today's program. All of you know her so very well. So, without wasting much time, I think we would like to listen to her precious words. Madam, we are very blessed to have you as special guest.
Thank you, Sneha. I am honored to be the guest of special guest. Or Jaideep has made me youngest member, so I am very delighted. And I think this program is going to enrich youngers more, because we have faced so many cases of obstructed labor that nowadays it is not seen so much. And to manage a case of obstructed labor is very, very difficult, because two lives are on risk, mother and fetus both. So Anju Agarwal is going to talk on this topic, and she is a very learned speaker. Her knowledge cannot be beaten for us. And you have involved so many LOCs member. It is matter of proud for me also. And I think other topic is panel discussion. That is also very important topic. So you have chosen very, very important topics and very practical topics. So let's hope this, and I wish all success. Many, many, many people should join this webinar. And all those who are fighting in the election, all the best. You all should win. So it is this thing. Okay? So
Thank you,
Sneha,
madam. Thank
Preeti, Chamila, and Anita, all the best.
Thank
Thank
you.
you, Sneha.
Thank you
Thank
so
you
much.
very much. Thank you.
Your blessings mean a lot to us, madam. Thank you so much. And dear friend, Dr. Priti Kumar, who will not know her, the vibrant personality from Uttar Pradesh. Naam hi kafi hai, madam. Over to you, Dr. Priti.
Thank you so much, Sneha. It is always pleasure and it's always pleasure to be part of your program. First and foremost, I would like to welcome the President of FOXI, Dr. Jaideep, and Charmila, Vice President of FOXI, to state of Uttar Pradesh. Thank you so much for being here. Respected Dr. Chandravati Madam and Dr. Anuradha Khanna and Dr. Manju Shukla Madam, high regards for you always. Dr. Kiran sir and Dr. Parag, I think you both are, so inspiring that always you encourage us in doing all the work. And thank you, everyone. And thank you, Sneha, for making me part. Thank you, Dr. Bharti, for your kind words. Anita, you are doing hard work. And all the best for you also. And when we decided about this program, we thought that we should take the best faculty. And I recommended the name of Dr. Anju Goel for this session on instrumental delivery. Charmila is excellent speaker and all the panelists and moderation. The panel moderation would be, I think, very highly useful to all the panelists. Thank you, Dr. S.P. Jaiswal, Madam, for being here. And all the best to you. And get well soon. And best wishes, Sneha. You have been putting a lot of hard work in every endeavor, and I've been part of your journey always. And we assure you that you will definitely go through with flying colors this time. Thank you so much. And thank you, Nutan, for being, the convener for this program.
Thank you. Thank you. Welcome, Preeti ma'am. Welcome.
Yeah, thank you so much, dear Priti, and all the very best to you, dear. Now I invite Dr. Parag Diniwale, the ICOG chair-elect, and of course, the national coordinator, a very dear friend to all of us.
Yeah,
so,
thank you, Sneha. Thank you. Don't waste time in introducing me. Thank you so much for the invite. As a national coordinator of AMOGS, it's a proud moment because our chairperson, Sneha, is heading one important committee, are spreading their wings and reaching out to other states, imparting knowledge, and there's a lot of exchange of academic views. So thank you, Sneha, for taking this up as an important job. Pleasure to be sharing the same dais as Madam Chandravati, Madam Manju Shukla, and of course, three of my ex-governing council members, Dr. Anuradha Khanna and Bharati and Charmila, are even going to be my governing council members next year. Thank you, Dr. Jaiswar, Dr. Deepa, with whom we have a long relationship in the Indian Menopause Society, and of course, other friends, Anju, Nutan, and everybody. And of course, last but not the least, Preeti, thank you all for joining. I'm not going to take much of your time, but my best wishes, Sneha, to you, to Preeti, and to Anita also for forthcoming elections. You are deserving candidates, and my appeal to all viewers to vote unanimously to these three women who are putting so much work for the organization. My best wishes to you. Thank you so much.
Thank you, Parag. Thank you so much. Thank you, Parag.
Thank you,
so
sir.
much. Thank you, Parag. Thank you.
We are blessed. We are blessed today.
My pleasure. Thank you.
So with this, I thank the God Almighty. I thank the respected seniors and all of you illustrious speakers and faculties. And without much ado, we go ahead with the academic session, and I hand over the mic to Dr. Nutan Upadhyay. I would ask you to cut short the introduction and go ahead with the, the much awaited academic session. I'm sure the speakers will throw so much light that everybody is enlightened. Thank you so much.
We are starting academic session with our first topic, that is obstructed labor. Who is illustrated speaker, Dr. Charmila Ayu. For this talk, I would like to invite our chairpersons, Dr. Sangeeta Rai, our president from Varanasi. She is again a very, very active and enthusiastic member of UPCOG. Next slide, please. Next chairperson is Dr. Nidhi Johari, who is at present the professor and head of Department of Saraswati Medical College, and she is at present the secretary of Lucknow OBGYN Society. And the third chairperson is Dr. Ishita Awasthi, who is the secretary of Varanasi OBG Society, and she is also a very, very enthusiastic member of our UPCOG. So I would welcome all our three chairpersons, please, and I would like you to introduce our illustrious speaker, Dr. Charmila Ayub. Please, Dr. Sangeeta, are you there?
Thank you, madam.
Yes.
And first, I would like to thank the office bearers of AMOGS and UPCOG for giving me the opportunity to be a part of this wonderful webinar. And without wasting time, I will invite Dr. Charmila Yavu, madam. She is at present the Vice President of FOXY 2024, and she is also the Vice President of Trichy Ops and Gynae Society. She is a Chairperson of Clinical Research Committee, FOXY 2016 to 2018. She is the ICOG Governing Council member 2021 to 25. She is also the National Coordinator of UNICEF FOXY PCA, MEDA FOXY PG program, is our Gurukul program 2022 to 23. There are so much of feathers on her cap. So the obstructed labor is a very important topic for all of us. Nowadays, the incidence has decreased, but yes, it is very much important to deal with such a case because we know that when there's a risk to both of the mother and the baby, we are fighting with it. So the most important is the early recognition and appropriate management of obstructed labor, which is crucial to prevent the acute maternal and the fetal complications. So without wasting time, I will hand over Madam Charmila to speak on this very important topic. Thank you, Madam.
Thank you, Dr. Sangeeta. Thank you so much for that very, very kind introduction. And I would like to thank Sneha for the opportunity. Wish her all the best, as well as one of my dearest friends, Dr. Preeti Kumar, that both of them should go ahead without any issues this time, as well as Dr. Anita. I'd like to wish her all the best. And people who are deserving will always go through, should not bother about, even though there are politics involved. But all three of you will go through with no issues. I would like to thank Sneha for the opportunity. I've already talked in the other program, but Sneha wanted me to do the same one. We think that obstructed labor does not happen in modern obstetrics, but let me tell you, there are so many constraints now and they are contributing to a higher risk of obstructed labor. Even though we have developed so much, we still will end up with this dreaded complication. On 10th January 2021 at 11:20 p.m., Mrs. L, who lives in rural Tamil Nadu, was a term pregnancy and had labor pains for almost 28 hours. Her husband and her acupuncture practicing father-in-law do not believe modern medicine. They attempt a home birth for Mrs. L, and she's brought dead to the local hospital. This is in 2021. It is not rare. The definition, according to WHO, about obstructed labor is, it is when the presenting part of the fetus cannot progress into the birth canal, despite there being strong uterine contractions. And it is worldwide 5% of live birth and accounts for almost 8% of maternal deaths till now. And it's more common in sub-Saharan Africa and parts of Asia. And it's seen between 0.56 to 1.89% of all deliveries in the referral hospitals of India, according to a study done in 2005. The etiology is, commonest cause is always CPD. And in developing countries, CPD is quite common because of the stunted growth of the maternal pelvic bones from malnutrition. There may be an early childbearing before the growth of the pelvis is complete because you've got teenage pregnancy still going on. Or there may be abnormalities in the shape of the pelvis due to rickets or osteomalacia. When there's an obstruction to passage of the fetus, the uterus will continue to contract in an attempt to overcome the obstruction. Then the upper segment fibers become stronger and thicker, and the lower segment fibers become longer and thinner. And then a demarcation line forms, and that is a physiological retraction ring. But if the obstruction persists, the demarcation becomes more distinct and it climbs higher and higher. Then it becomes pathological and it's called as a Bandel's ring now. Then the stretched lower segment becomes very friable and it threatens to rupture with further contractions of the uterus. The fetal head gets jammed in the pelvis in an obstructed labor. The bladder is compressed between the pubic bone and the fetal head. The bladder becomes edematous, may even undergo pressure necrosis, can lead on to a fistula later on. With unrelenting labor pains, and the baby becomes hypoxic and may even die. With more of labor pains, the uterus can rupture. But remember that a primary uterus can develop uterine inertia, but the multigravid uterus will rupture quite quickly compared to a primary gravid uterus. So how do you diagnose obstructed labor? There will be a history of prolonged labor. On clinical examination, you will have signs and symptoms of obstructed labor. And very commonly, they would have been referred from a small facility or they would have attempted a home delivery. On general examination, the mother will have features of distress. She may be exhausted, can even have ketoacidosis, will be dehydrated. The pulse rate will be more than 100 per minute. She may have a raised temperature and she'll be throwing up very, very scanty urine. On abdominal examination, the retraction ring, Blandel's ring will be seen and it will be felt between the tonically contracted upper segment, which is thick, and the distended, tender, stretched lower segment. There will be a distended urinary bladder. The fetal heart may be showing an evidence of fetal distress. On common cases, it can be even absent. On vaginal examination, the vulva is usually swollen and edematous. The vagina is dry, hot, and is occasionally offensive and purulent discharge. The cervix will be almost fully dilated or hanging like a curtain. The presenting part is extremely molded and jammed in the pelvis, and there may be a huge caput formation on the baby. How will you manage? There should be an immediate management. There should be some general management principles and the obstetric management. In the immediate management, start IV fluids, at least 1 liter of crystalloids, which can be ringer-lactate or normal saline, but to hydrate the mother. Drain the urinary bladder with an indwelling catheter. Send blood for typing and cross-matching. Start on antibiotics, which are broad-spectrum coverage, and metronidazole should be added, and obtain an informed consent from the patient and her attenders. There should be a preoperative checklist for obstructed labor so that you can verify the management protocol and the timelines of interventions from decision to arrival in the operation theatre should be prepared. There should be a review by a specialist at least once during the process of labor to delivery, either in person, by phone, or during major service ward rounds. And cesarean section should commence within the next 1 hour if you have diagnosed obstructed labor. There should be an interval from decision to theatre arrival of less than half an hour, and from theatre arrival to delivery baby should be less than the next half an hour. And how will you deliver the fetus in obstructed labor? You should first exclude a uterine rupture by clinical examination and ultrasound. And on a PV examination, the cervix is fully dilated and the vertex is at or below the ischial spines. If the baby is dead, it's better to go for a craniotomy and a vaginal delivery. But if there's a live baby with the cervix fully dilated and the vertex engaged already, you can go for a forceps delivery. But if there's an impending rupture with an over-distended lower segment, either if it's live or dead, it's better that you go for a cesarean section. And you need to have the skills for destructive vaginal operations. When there's an intrauterine infection and already the fetal death has happened in obstructed labor, it is better that the baby is delivered by vaginal delivery. And just because there's a lack of skills, it's not right that an emergency cesarean should be done, because it's a very, very high risk of sepsis when there's an obstructed labor and the baby has died. And the role of destructive operations in obstructed cases with dead or moribund fetuses is always superior to cesarean sections in many studies. And when you the precautions you will take when you're going for an emergency cesarean is the incision of the intravesical peritoneum should be as high as possible to avoid a bladder damage. The incision should be large enough to avoid a lateral extension. You need an expert assistant to dislodge the head if needed, if it's impacted. You need to check for malpresentations before surgery and to be prepared to deliver by breech extraction whenever necessary. And please do an uterine exploration after delivery for downward or lateral extension, because the lower segment is extremely thin. There's always a dilemma in diagnosis of obstructed labor, because we feel that we should not rush for a cesarean section. At the same time, we feel that the labor should not get obstructed. And there needs to be a balanced view between operative delivery and preventing an obstructed labor. And the decision has to be made on the basis of objective measurable parameters. And that's why a checklist is very, very important in all the wards. There needs to be a method of evaluating the risk of labor disorders, because it has evolved over the years. And the criteria for diagnosis of obstructed labor is a major criteria is the mother has been in prolonged active labor of almost 8 hours in a primipara and almost 6 hours in a multipara with regular uterine contractions. It is a major criteria for obstructed labor. And the minor criteria is when the dilatation is less than 1 centimeter per hour for primary and less than 2 centimeter for a multi. There's a protracted descent of the fetal head at less than 1/5 per hour in primary or less than 2/5 per hour in a multi. There's an arrested cervical dilatation of more than 3 hours for a primary and more than 2 hours for a multi. There's a descent which is arrested for the presenting part of almost like more than 1 hour. Or there's a prolongation of second stage of more than 2 hours in a primary or more than 1 hour. And when there's a presence of severe caput and molding, these are all minor criteria for diagnosing obstructed labor. The classical pattern in CPD is secondary arrest of cervical dilatation, and there would have been a normal initial cervical dilatation followed by no dilatation at all. And it's very complex when disproportion is exacerbated by occipital posterior positions or secondary failure of uterine contractility, which occurs with prolonged labor. And how will you, what are the methods to prevent obstructed labor? Early recognition is very important. Immediate intervention is needed. You need to utilize a partogram to monitor the labor to know whether it is going for a prolongation. And you need to have a provision for emergency obstetric care at every level. Partograms are known to prevent obstructed labor, and there will be a resort to early operative delivery when progress is slow, and that is an USAID recommendation. There's something called a labor scale which has come now, and it's a modified version of the WHO partogram. Here, the alert and action lines have been replaced by a scale of cervical dilatation. It minimizes the diagnosis of labor dystocia, but it will not increase the risk to the mother or the fetus because of prolonged labor. And this is the difference in the WHO partogram, which has come in 2019 to the one which was given earlier. The difference is now the definition of active phase. Earlier, it was 4 centimeters. Now WHO has changed it to 5 centimeters when active phase starts. There's nothing like the earlier they had a fixed 1 centimeter per hour alert line and action lines, but now there's evidence-based time limits at each centimeter of cervical dilatation. That is how many hours it takes for each centimeter of dilatation is now marked. There's no second stage section in the earlier partogram. Now there's an intensified monitoring in second stage. There's no recording of any supportive care interventions earlier, but now there's a recording of the labor companion provided, the pain relief given, the oral fluid intake of the mother, and the posture she's taking for labor. And earlier there was monitoring the strength, duration, frequency of uterine contractions, but now the strength is not monitored. Only the duration frequency is monitored. There's no requirement to respond to deviations from expected observations of any labor parameter earlier, except the alert and the action lines. But now every deviation is highlighted and the corresponding response which is done is recorded by the provider. Why has the change happened in the diagnosis of labor dystocia? It is because there are conditions where the labor can progress very, very rapidly and then get arrested. And then it will take more than 2 hours to then reach the action line. So you would be thinking that it's going on well, but it actually would have been arrested. On the other hand, the labor can be very slow as a result of inadequate uterine activity. It would have crossed the action line, but suddenly it will progress normally, and we think the problem is persisting, but actually it would have become normal. So the anxiety which is formed because being on the wrong side of the action line can help you, can actually be unhelpful in terms of guiding progress for the rest of labor. And that's why they changed to the evidence-based time limits rather than the alert and action line. And when will substandard obstetric care happen and can lead on to obstructed labor? When there are questionable decisions in the case of cesarean sections, suppose it's a delayed preoperative intervention, and when there are too few assisted vaginal deliveries, when the art of doing instrument delivery is lost, they may lead to substandard obstetric care, and an inadequate use of partograms can lead on to a substandard obstetric care. So what are the recommended interventions to improve the diagnosis of obstructed labor? Always there should be a list of agreed upon criteria by a unit, and there should be a standard diagnosis of obstructed labor in all the departments of the hospital or pertaining to labor. They should be same for the labor ward and the operation theatre. The midwife in charge and the specialist on call should periodically remind doctors to adhere to criteria during grand rounds and routine work. That is, when they are monitoring in the labor ward, there should be the basic protocol which should be followed by everybody, from the midwife to the specialist to the doctors who are looking after the patients. And always confirm the diagnosis of obstructed labor in the case notes according to posted criteria when the patient is sent to or received in the theatre. So there's a uniformity everywhere. Promote the utilization and interpretation of partogram with regular training of the personnel on use during the ward rounds. Encourage doctors at the referral points like in labor ward and operation theatre to use the posted criteria to confirm diagnosis before referring patients because of obstructed labor. And the recent changes which we need to know to prevent an obstructed labor is a redefinition of labor disorders, the usage of intrapartum ultrasound for the diagnosis of cephalopelvic disproportion, and the condition called obstetric dilemma. And the changes which has happened in the guidelines definition of labor is American College has gone on up to 6 centimeters, RCOG is still at 4 centimeters, WHO is at 5 centimeters. Progress according to American College is 0.5 centimeters per hour and not the earlier 1 centimeter per hour, and that's similar to Royal College. Now the arrest is defined as no progress with oxytocin for almost 4 hours when there are inadequate contractions, and when there's no progress for almost 6 hours with inadequate contractions, this is called as arrest. Royal College says no progress after 4 hours of oxytocin. Now the second stage arrest is now 3 hours for a primary, 2 hours for a multi, and you have to add one more if there's an epidural. So almost second stage, you can wait for 4 hours for her to deliver. Royal College is little conservative. They said 3 hours and 2 hours for a multi. WHO recommendation is for an intrapartum care for a positive childbirth experience. They've agreed not to recommend the 1 centimeter per hour threshold and the alert line to assess labor progress. And they've accepted that the threshold of 1 centimeter per hour is suboptimal for identifying women with the risk of adverse birth outcome. Because in addition to the risk of false negative findings, the risk of false positive also may be high, and that may lead to unnecessary labor intervention just because the patient has not achieved that 1 centimeter per hour. And the intrapartum ultrasound will help to diagnose labor dystocias because we know that fetal malpositions and cephalic malpresentations are well-recognized causes of failure to progress in labor. The traditional obstetrics emphasize the role of digital examination or regular PV examinations, but recent studies demonstrated that this approach is inaccurate and intrapartum ultrasound is far more precise. A combination of a abdominal scan with a transperineal scan will allow an accurate diagnosis of a normal and abnormal position of the head, flexion, and the syncretism of the fetal head. Intrapartum translabral ultrasound is more accurate and allows for an objective assessment of labor progress. And recent studies have said that fetal head engagement can be based on the following parameters, and that is the angle between the pubic symphysis and the fetal head. The more obtuse it is, it's more difficult because it means it's mal-rotated. The distance between the presenting point and the interspinous line will tell you accurately how much the fetus is descended. And the fetal head direction, the birth canal, can also be found out with the intrapartum ultrasound. The advantages is ultrasound is more precise about the position of the baby and the station. Women seem to prefer ultrasound to digital examination in labor. The trans-abdominal ultrasound can be used very commonly for fetal lie-in positions for the occipital and anterior and posterior positions. And transperineal ultrasound can be used for the location of the head station. And this is how an occipital anterior will look with an ultrasound. Very, very easy to diagnose. Occipital posterior, very, very easy. You need not go and check for the fontanelles again and again to see whether it is rotated or not. And what is the obstetrical dilemma that is causing problems? It is the fit between the maternal pelvis and the neonatal size at delivery. But the fit is not as good as it was earlier because there's a double burden of malnutrition and obesity epidemic, which is happening globally, and that is reshaping the obstetrical dilemma. Maternal obesity will increase the risk of macrosomic offspring. When the mother is short and also she has got a risk of gestational diabetes, she's going to have a bigger baby with gestational diabetes with the short stature that is going to add to the burden. And this association between the dual burden of malnutrition and the obstetrical dilemma is expected to increase in the future because the obesity epidemic is emerging faster than when stunting is being resolved. And the other epidemic which is causing problems and is leading on to more of obstructed labors is social media. On Thursday, July 26, 2018 at 8:20, a couple allegedly attempt a home birth with YouTube videos and the mother bleeds to death. This happened to Kritika and Tirupur, who died due to excessive bleeding on July 22 at home after delivering a baby. And we have to prevent the 3 delays to avoid obstructed labor, and that is a big study which was done and was published in BMC Pregnancy Childbirth. The delay in decision making is a delay 1, which will cause an obstructed labor. The delay in a lady accessing care is the second delay. And the delay in receiving timely appropriate care or treatment is delay 3. And remember to focus on supply and demand interventions to improve outcomes in pregnancy. So I'd like to conclude by saying the incidence of obstructed labor, remember, it's an indicator of inadequate care and poor quality of obstetric care anywhere. Neglected obstetric care, obstetric labor will result from poverty and prohibiting high cost of maternal care in hospitals, which still occurs in some parts of India. The ignorance and illiteracy of patients, the obstructed transportation, the socio-cultural belief which seems to permeate everywhere that a vaginal delivery has to be done at any cost, and the late referrals which happen because of that, and also the aversion to cesarean section in hospital delivery, especially after previous cesarean operation, seems to lead on to more of obstructed labor and the problems with that. So the take-home messages will be, remember that sepsis, PPH, ruptured uterus are causes of maternal death in obstructed labor. promote the antenatal care service utilization during pregnancy, improve the referral system, have an infrastructure that has the capacity to manage obstructed labor, use partograms in all your labors, use intrapartum ultrasound when necessary for a better outcome, and reduce maternal obesity. Thank you so much, Sneha, for the opportunity. I would also like to acknowledge Dr. Bharati, who's there. Thank you so much. And Dr. Nutan for the coordination. Thank you.
Thank you, Dr. Charmila ma'am, for such an excellent talk. Now, I would like to invite Dr. Nidhi Johari and Dr. Ishita Awasthi to give their concluding remarks. Dr. Nidhi Johari, are you there, please? And Dr. Awasthi? Dr. Ishita Awasthi? I would now request Dr. Sangeeta. Yeah, and...
Thank you, madam. Thank you, madam. Thank you, Charmila, madam.
Thank you, Sangeeta.
You are always the best, madam. I've had you in many webinars and lectures. And yes, it is another very excellent lecture, ma'am. You have brought all the important highlighted points which all we should follow in our labor room. And the most important is the importance of labor care guide over the partogram and also the use of intrapartum ultrasound, madam. So this is very much important, and yes, it is much benefited for all of us and also for postgraduate. So always the preventive measures like careful observation, proper assessment of these patients and picking of these patients early, and early detection and management of the cases of obstructed labor will help both of the mother and the fetus and the managing doctor to very good outcome. So thank you, madam, for such an excellent lecture. We are blessed. Thank you, Nutan ma'am, for the coordination.
Thank you so much, Charmila, for that excellent talk. And I would especially congratulate you for, bringing up this concept of that, the misconception that obstructed labors have become uncommon. In fact, they are still there and we have to face it. Thank you so much, Charmila.
Thank you, Sneha.
Excellent job. Excellent talk, Dr. Charmila. It's really very good.
Thank you, ma'am. Thank you so much.
Thank you, ma'am. Thank you once again for such a crisp and lustrous talk.
Yeah, sure.
Thank you so much for your being there and enlightening. Now, I would like to take us to our second topic. And we have another illustrious speaker with us, Dr. Anju Agarwal, ma'am. And for that, I would like to invite our chairpersons, Dr. Deepa Kapoor, ma'am. Welcome, ma'am.
Thank you.
We know that she is the assistant director of in Tender Palm Hospital, Lucknow. She has been the vice president of Lucknow Menopause Society. We welcome you, Deepa Kapoor, ma'am, and we are so happy to have you with us. We have Dr. Renu Sirohi Gupta, who is the president of Firozabad OBG Society. I welcome Dr. Renu Gupta, and we also have our third chairperson, Dr. Samta Gupta. She is the secretary of the Greater Noida OBG Society and a very, very dynamic and practicing gynecologist in Greater Noida. I welcome Dr. Samta Gupta also. Now, I would like to request Dr. Deepa Kapoor, ma'am, to introduce our illustrious speaker, Dr. Anju Agarwal. Please, ma'am. Welcome.
Thank you so much, AMOGS and UPCOG for having me here. And it is a great pleasure to be here with so many stalwarts of OBS and Gynae. And I would like to say that vaginal delivery, instrumental delivery was very rampant during our times, but now gradually it has become a dying art. So with the resurgence of so much of the very high incidence of cesareans, so the instrumental delivery is again showing a resurgence, and we would hear about it from a very learned speaker, Dr. Anju Agarwal, who is at present the HOD Department of OBS and Gynae. She's a Vice Dean Academics, KGMU, Lucknow. She has more than 100 national and international publications, and she has presented a number of papers in national and international conferences. She's a winner of several awards. She's a past chairperson, North Zone ISOPAP, past president, Lucknow chapter ISOPAP, executive member of ISOPAP, Vice President North Zone ISOPAB, and involved in various research products. She has participated as an expert in development of Government of India national guidelines on calcium supplementation, deworming, GDM, and hypothyroidism. So I would now request Dr. Anju to kindly speak on the topic, the instrumental vaginal deliveries.
Thank you so much, Dr. Deepa, for your kind introduction. Is my slide visible?
Yes, ma'am. Yes, ma'am, it is.
A very good evening to all our stalwarts from FOXY and dear delegates. And initially, I would like to congratulate Dr. Sneha on organizing such wonderful webinars. And thank you so much, Preeti and Dr. Sneha, for inviting me here today. And best wishes to both of you for your elections. I'm sure both of you will come out to be winners. So as we have already, Dr. Sharmila has already set the stage for assisted vaginal delivery. And I was so happy to see that she also mentioned assisted vaginal delivery as a option to overcome obstructed labor. And Dr. Deepa also mentioned it's a dying art. So let's see what is the problem with this. We all know that the second stage of labor is one of the most dangerous periods for the baby, and potentially it may be associated with serious complications for the mothers also. And operative vaginal delivery, though it has been used since long times, it has also been maligned since the days of far back as W.J. Little, when the word forceps came to become synonymous with birth injury and cerebral palsy. But that is not really so. Though forceps and ventouse may be associated with complications, we should remember that they are all rare and mainly associated with mid-pelvic and rotational deliveries. And on the same hand, we need to remember that the second stage cesarean too is very challenging. It is not a very easy procedure, and it may itself result in significant maternal and perinatal morbidity. And the story does not end there. The story continues for the obstetric future. As per NFHS 5, 88% deliveries are institutional. But as Dr. Sharmila also highlighted, many of these deliveries, the patients are coming late. They are already coming in obstructed labor. They are already coming with rupture uterus. So though they are institutional deliveries, but they are not getting the optimal obstetric care, because only 58% of them have availed antenatal care. So a woman who has undergone a second stage cesarean coming late in labor is much, much highly likely to result in a rupture uterus. Because again, second stage cesareans are more likely to have extension of incision in the upper segment or even a T incision. And that is why assisted vaginal delivery is a very important art which all obstetricians should know. WHO also lists it as a signal function of basic emergency obstetric care. So remember, it is part of the basic emergency obstetric care services. But despite that, when we look at the figures, we find it is really a dying art. In USA, only 5 to 6% deliveries are assisted vaginal deliveries. In UK, the show is better, 14 to 15% of deliveries. And India is lagging far behind with only 2 to 3% of deliveries. And that is why we are having a cesarean pandemic in our country. And we need to revive assisted vaginal delivery. What are the methods which we can use to promote a normal vaginal delivery? We know incidence of assisted vaginal delivery increases with epidural analgesia, but that does not mean we do not give epidural analgesia when the woman wants it. And we should remember that the incidence of assisted vaginal delivery is not affected by early initiation of epidural analgesia or by discontinuing it when the woman is pushing. But an important intervention which we can do is allow the woman to adopt the upright or lateral position in the second stage of labor, which helps to promote spontaneous vaginal delivery. There is no role of prophylactic manual rotation in the second stage of labor, and there is no role of routine oxytocin augmentation to prevent assisted vaginal delivery. The indications of assisted vaginal delivery, I think we all know. Any fetal compromise in mothers, lack of continuing progress for 3 hours with regional analgesia or 2 hours without regional analgesia. And these guidelines, as Dr. Sharmila also emphasized, have been recently revised to make it 4 hours and 3 hours. And for the multi-women, it is 3 hours and 2 hours. Maternal exhaustion is an indication, and medical indications where you want the woman to avoid the Valsalva maneuver, like preeclampsia, heart disease, severe anemia, are again indications of assisted vaginal delivery. Depending upon the level of the fetal head, it may be classified into outlet, low, or mid cavity. Outlet deliveries are where the fetal scalp is bulging at the perineum. Low deliveries are where the fetal skull is at +2 station. It may be non-rotational or rotational. And mid-cavity deliveries are when the fetal head is no more than 1/5 palpable abdominally, and the leading point of the skull is at 0 or +1 station. An important point here to remember is we must do an abdominal examination in all cases. And before attempting any assisted vaginal delivery, the head should not be palpable abdominally. Sometimes we may get a false impression of the head being low down in the pelvis due to the presence of caput and molding. So, no assisted vaginal delivery should be conducted without doing an proper abdominal examination or intrapartum ultrasound. There are certain special situations which we must discuss. In cases of suspected fetal bleeding disorders or predisposition to fracture, then it becomes a relative contraindication to assisted vaginal delivery. But HIV, hepatitis B, and other blood-borne viral infections in the mother are not an absolute contraindication to assisted vaginal delivery. We always need to weigh the pros and cons against a cesarean where a woman may not return for delivery in time against a assisted vaginal delivery. Vacuum extraction is not contraindicated following fetal blood sampling procedure or application of fetal scalp electrodes. But yes, it is contraindicated in the preterm babies less than 32 weeks of gestation, and it should be used cautiously between 32 and 36 weeks of pregnancy. Before any forceps or ventouse, we must ensure that the prerequisites are fulfilled, which, as I already emphasized, the head should not be palpable abdominally. Besides all others, an informed consent must be taken. It may be taken orally, but it must be documented in the records. Ultrasound assessment of the fetal head position prior to assisted vaginal delivery is more reliable than clinical examination. There is insufficient evidence to recommend the routine use of abdominal or perineal ultrasound for assessment of station. So it is not that if you do not have access to ultrasound, you should not do an assisted vaginal delivery. And except for outlet forceps, all other deliveries are to be performed in the operating theatre with full preparation for cesarean section if required. And that is why it is recommended that all assisted vaginal delivery should be considered as a trial of delivery, not a matter of ego that we have to deliver the patient vaginally. Another very important aspect is we must know to use the correct instrument. For outlet forceps, the short curved forceps are recommended. For the low forceps and any abnormal presentation or position like occipito-posterior or after coming head of breech, the long curved forceps must be used. So this is a short curved and the long curved forceps. And this is a very important point to remember. The steps of the forceps or vacuum.
Yes,
Saidi, can you check?
Yeah.
Yeah.
Mute yourself. Yeah.
Steps of the forceps and vacuum are easily remembered by the ABCD mnemonic, which is A for assistance and anesthesia. B is bladder should be empty. For C, cervix should be fully dilated and membrane should be ruptured. D is determine the position of the head. E is check the equipment. F, apply forceps. G is gentle traction. Very important, the word gentle. We should not hang on the forceps. We should only apply enough traction which we can with our forearms. H is hand elevation. I is incision or episiotomy if required. And J is for jaw, that is remove the forceps when the jaw is visible. The same mnemonic is there for ventouse, with the only difference that for F, you check the fontanelle to place the cup. And for H, halt in between contractions, or if more than 3 pulls, or if more than 2 pop-offs. Analgesia is very important whenever you are doing a assisted vaginal delivery. Perineal block may be sufficient for a low or outlet birth. For mid-pelvic or rotational delivery, regional block is required, though mid-pelvic and rotational deliveries are usually not being practiced and are not so recommended in today's scenario. But yes, low and outlet delivery should definitely be conducted. Pudendal block may be used to save time in urgent situation for the mid-pelvic deliveries. Now, which one to use? Forceps or ventouse? The most important thing is use the instrument appropriate to the clinical situation. For example, if it's a preterm baby, you'll have to use the forceps. But at term, use according to the operator expertise. Remember, ventouse is more likely to fail, more likely to be associated with cephal hematoma, retinal hemorrhage, maternal worries about the baby, but it is less likely to be associated with significant perineal and vaginal trauma. There is no difference in the odds of cesarean, low 5-minute APGAR scores and need of phototherapy. And again, among the vacuum, the soft cups have a higher rate of failure, but they have a lower incidence of neonatal scalp trauma. It is very important we should know when to stop. As I said initially, we should consider all deliveries to be a trial of delivery. So when do we discontinue ventouse? When there's no evidence of progressive descent with moderate traction during each pull of a correctly applied instrument, complete vacuum assisted birth in the majority of cases with a maximum of 3 pulls, which should bring the fetal head at least on the perineum. We evaluate if there's minimal descent with the first 2 pulls and discontinue if there have been 2 pop-offs of the instrument. Remember that the negative pressure buildup should be rapid as it reduces the duration of the procedure, and there is no difference in the maternal and neonatal outcomes as compared to slow pressure application. Is there any role of sequential assisted vaginal delivery? Very little, because it is associated with an increased risk of trauma to the baby and increased risk of obstetric anal sphincter injury in the mother. Similarly, for forceps, we must discontinue if you cannot apply the forceps easily. The handles do not approximate easily. You need to apply force, or if there is a lack of progressive descent with moderate traction. We should discontinue forceps birth if birth is not imminent following 3 pulls of a correctly applied instrument. Here it is very important that for the low applications, we must use a long curved forceps. If we are going to attempt it with the short curved forceps, we are more likely to cause trauma to both the mother and the baby and more likely to fail. We must reevaluate if there is minimal descent with the first 1 or 2 pulls of the forceps, and we discontinue rotational forceps birth if rotation is not easily achieved with gentle pressure. So the important word here is gentle. Your traction should be gentle and your pressure should be gentle. When are we more likely to fail? When maternal BMI is more than 30, the mother is short, estimated fetal weight is more than 4 kg or it's a clinically big baby, head circumference is more than the 95th percentile, occiput or posterior position, or when we are attempting a mid-pelvic birth. When you are doing a cesarean following a failed assisted vaginal delivery, definitely there's an increased risk of neonatal morbidity and fetal head impaction. So you may consider suppression of contractions while preparing for the cesarean delivery, especially when the decision to delivery time may be delayed. But in general, it is recommended you do the delivery, attempt the delivery in the OT so that there's no delay between the assisted vaginal delivery attempt and your cesarean. There is no robust evidence to support routine or restrictive use of episiotomy at the time of vaginal birth, and the decision should be tailored to the circumstances at the time and the preferences of the woman. There is evidence to support use of mediolateral episiotomy at assisted vaginal birth, in that it helps in preventing anal sphincter injury, especially for nulliparous women. And whenever you are performing a mediolateral episiotomy, the cut should be at 60-degree angle, initiated when the head is distending the perineum. It should not be given prior to applying the forceps or immediately after applying the forceps. Give 1 or 2 pulls, allow the head to come down, and then give the episiotomy. It will reduce the blood loss, allow you to give only the episiotomy when it is required and as much is required. A single prophylactic dose of intravenous amoxicillin and clavulanic acid should be given following assisted vaginal delivery. Here the important word is it should be given following the assisted vaginal delivery, because amoxicillin, clavulanic acid are not recommended prior to delivery. But post-delivery, if it is given, it has been found to reduce the confirmed or suspected maternal infection compared to placebo. It is recommended that good standards of hygiene and aseptic techniques are followed in all cases. Postpartum bladder care is very important. We must educate the woman to pass urine repeatedly. Timing and volume of the first void urine should be monitored and documented. And a post-void residual should be measured if urinary retention is suspected. Women who have received regional analgesia for the delivery should have an indwelling catheter in situ for 6 to 12 hours post-delivery. And all women should be offered physiotherapy-directed strategies to reduce the risk of urinary incontinence at 3 months. Complications, we know in the mother there is episiotomy, more likely in forceps. Significant vulvovaginal tear, again more likely in forceps. Anal sphincter injury, more likely in forceps. Postpartum hemorrhage, equal incidence in both. Urinary or bowel incontinence, again common at 6 weeks but improves over time. Maternal death is very rare. For the perinatal, Cephalhematoma is more likely with vacuum. Facial or scalp lacerations, equally found with both. Retinal hemorrhage, again more likely with vacuum. Jaundice, both have equal incidence. Subgaleal hemorrhage, more likely with vacuum. But serious neonatal injuries are more likely with forceps, like cervical spine injury, intracranial hemorrhage. But important to remember, they are very rare and only occur with undue application of force. So it is very important for us to know when to stop and not to apply too much force. And we need to counsel the women that there's a high probability that if she has an assisted vaginal delivery in this pregnancy, she'll have a spontaneous vaginal birth in subsequent labors. To reduce the complications of forceps and ventouse, a Odon device has been developed in Argentina, which is basically a sleeve which surrounds a fetal head and protects it from trauma, but it is still undergoing evaluation and is not yet in the open market. So how can we optimize the outcomes in cases of assisted vaginal delivery? We need to train our medical students well on models and then on patients. We must all know when to abandon the procedure. We must avoid prolonged traction, excessive force. We have to follow the guidelines, take informed consent, ensure asepsis, and post-delivery care. So, assisted vaginal delivery has a definite position in modern obstetrics. It is very important to fight the cesarean pandemic. The trend is to prefer ventouse worldwide, though there is no compelling evidence to support it. And preserving forceps as a choice for operative vaginal delivery is important, and it mandates training in forceps techniques during medical residency. Thank you so much.
Thank you, Anju Agarwal ma'am, for such an exhaustive talk on this such an important topic of assisted vaginal delivery, which has to be revisited once or time and again, because we have to keep relearning it and revisiting these topics.
Yes, Nutan, can we
and
have?
now I would like to.
Yeah,
I would like to request Dr.
Just a moment, Nutan. We would like to have the chairperson's comment.
Yeah, I was inviting
a few moments later. May I invite Dr. Rajendra Singh Pardesi, the immediate past president of AMOGS, for his precious words of guidance and blessings. So we would like to request you, sir, to speak few words. Over to you, sir.
Thank you. Sorry, because I was stuck up in emergency, but it's a really excellent webinar. I am feeling proud and honored to be a part of this program associated with UPCOG, basically, and in the leadership and of Dr. Chandravati, Dr. Anuradha Khanna, Dr. Manju Shukla, and the stalwart Dr. S.P. Jaiswar, Dr. Kirti Dubey, and Bharti Maheshwari Priti Kumar. I wish to congratulate Dr. Sneha Boyar for organizing this webinar on the topics, and they are very important to reduce maternal mortality. As I was listening to Dr. Anju Agarwal, it was really an excellent talk on assisted vaginal delivery. I'm very fond of forceps and vacuums. I am still using forceps and vacuums. She explained very nicely. And with that, not only cesarean section rate, but it also reduces maternal morbidity, mortality also. So with the galaxy of speakers, panelists, chairperson, I think this is going to be a great event. I wish every success to Dr. Sneha Boyar for her future endeavor in FOXI, in forthcoming election as Vice President. Even Dr. Priti Kumar is there. I wish every success to Dr. Priti Kumar for her future endeavor in forthcoming election as Vice President, and to Dr. Anita Rajoria also.
Thank you, sir.
In chairperson election. Thank you so much for inviting me. I don't want to in between you and scientific content. Thank you so much.
Sir, your blessings mean a lot to us.
Thank you so much, sir, for your gracious presence in spite of your busy schedule. And thank you so much for your blessings and your words of wisdom, sir. Thank you so much. May we have the comments from the chairpersons now. Over to you, chairperson.
Thank you.
Dr. Deepa Kapoor, ma'am, can we have your comments, please, ma'am?
It was an excellent lecture, definitely by Anju. And definitely nowadays, in the light of the fact that there's so much increase in the cesarean rates, the postgraduate especially should be taught about the vaginal, about these assisted vaginal deliveries, and they should be more confident in carrying out these deliveries also. And they should have more patience when the patient is laboring, because nowadays they don't have patience to see the patient through, and the patient also needs to be counseled properly, because just even after a few labors, contractions and all, they will say, now I want a cesarean, I can't go through this. So they have to be counseled very well. So patient counseling is a very important part of assisted vaginal delivery. So all this needs to be reinculcated in the patients as well as the residents to further this art again.
Thank you, ma'am. And then we also have Dr. Samta Gupta here from Greater Noida. Dr. Samta Gupta, line from you also, please. She is the Secretary of Greater Noida Obstetrics Society.
Thank you, UPCOG and AMOGS, for giving me this opportunity. In fact, it was a very excellent and a crisp lecture. And I would just like to add only one thing, that since we are not teaching our postgraduates, so that is why it is also becoming a dying art. So we should have we should be able to teach the postgraduates and different ways. We need to tell them how to basically apply the forceps and vacuum. And ma'am has very correctly said that the patience is required very much, so that we prevent the more and more of the cesarean sections, and we can prevent the cesareans by this assisted vaginal delivery by applying forceps and vacuums. So that is very important, so that it doesn't become a dying art, and we still are able to practice this.
Thank you so much. Again a warm welcome and thank you, Dr. Rajendra Singh Pardeshia, sir. And I hope we are going to listen to you also on this very you're so well. You're trained and so you are a professor in this line of assisted vaginal delivery. So it will be a really learning experience learning from you, sir.
Actually, it is really, she told nicely, it is our fault. We are not teaching our residents. And Dr. Anju Agarwal has explained very nicely. It's an art. If we will teach them, if we will learn, then we can perform. And basically, it's a both part, because people are now afraid of doing this because of the Consumer Protection Act. Because if anything goes wrong, the patient will be blaming on us. No, due to आपके वो forceps चिमटे से हो गया, आपके वो कब से हो गया. So this is meant, so we should have support from government. So see, we appeal all to government, because see, collectively now you are UP means UP is a major state in India. So please remove gynecologists from Consumer Protection Act, and due to that also, so our people are afraid of doing this assisted vaginal delivery. And actually, it's an art. Really, we shouldn't forget it.
Thank you, sir. Thank you, sir.
Thank you, sir. And thank you so much, chairpersons, for gracing the program and your wonderful comments. Definitely, all of us agree to this, that all of us learn this art and science of, instrumental vaginal delivery, and all of us teach our postgraduates so that, the circle continues and the process goes on. I'm sure this not only reduces maternal mortality, morbidity, but also reduces the perinatal mortality and morbidity. And with this, we conclude this session. Over to you, Dr. Noor.
Thank you. Now we come to the third part of our academic meet. And for this, I would like to invite my co-coordinator, Dr. Anita Rajoria, ma'am, to take this academic session further. Dr. Anita Rajoria, ma'am, please, can you please take over the academic session further?
Yeah, thank you, Sneha, ma'am, and thank you, Nutan. Thank you for being so supportive in the execution of this program. Now we move over to the much awaited panel discussion by moderator, Dr. Sneha Bhuyar, ma'am, who's the convener of this program also. Madam is the candidate for Vice President Foxy West Zone. We all know her so well. She has done beautiful work while she was chairperson of Breast Committee, and she gave all of us good opportunity to work for her committee. Madam has been awarded Asia GCC Award, SN Malhotra Individual National Award, Durusha Distinguished Community Service, and so many other Champion of Foxy Award, Anandbhai Joshi State Awards. Madam has been chairperson, as I have already highlighted. She's a governing council member, ICOG 2122, National Adolescent Trainer, WHO FPAI certified, National Expert UNICEF, peer reviewer for Jogi, AMOGS chairperson, medical disorder, emergency obstetrics, under which committee under which we are holding this webinar also, Mission Pink Health Committee and convener, PCP NDT, SAFOG working group member on breastfeeding.
Thank
So,
you,
so many credits to her. So, over to you, Sneha ma'am. And we have as expert Dr. S.P. Jaiswal ma'am. Ma'am is MS, FICH, FIOG, RCOG, professor and head department of OBGYN at KGMU. A lovely person, a very nice person, very, very cooperative senior. Many honors and award to her credit, like MS Signature International Faculty Award, Outstanding Faculty of Year 2023, Hall of Fame 22. So many awards have been given to her. She's a great academician and a very nice person. Welcome, respected Jaiswal ma'am, for your
Thank you, Dr. Anita. At present, I'm retired from KGMU and joined as a HOD in Medical College.
Okay.
So
welcome, ma'am. Ma'am, should I invite panelists also?
Yes,
okay.
yes.
So, as a worthy panelist, we have Dr. Apeksha Vishnoi. She's the Director, Department of OBGYN and Infertility at Alantra Medicity Super Specialty Hospital and Oscar Women's Clinic at Lucknow. She's ex-HOD Saraswati Hospital and Research Center, Lucknow. Lecturer, Mayo Medical College, Barabanki also. So many, winner of so many awards. And her special interest is in fertility, hysteroscopy, colposcopy, etc. So welcome, Dr. Apeksha. Then we have Dr. Indulata Sahu. She is MD DNB MICOG. So many credentials to her. Professor OBGYN, Maternal and Reproductive Health, SGPGI, Lucknow. She has 32 national and international publications to her credit, contributed through 3 book chapters, presented various papers in national and international
Dr.
conferences.
Anita, I can take over, and I would like to welcome all our panelists, Madam S.P. Jaiswal, Apeksha Vishnoi, and of course, Dr. Indulata Sahu, Dr. Shruti Jain, who is the Associate Professor, Department of OBS-GYN, BHU, and life member of FOXY. We welcome you, Dr. Shruti Jain. We welcome Dr. Mamta Singh, who is the Associate Professor in Department of OBS-GYN at BHU, Varanasi. And of course, lots of awards and accolades to her credit also. We welcome you, Dr. Mamta Singh. Dr. Vanita Maske, the consultant obstetrician and gynecologist at Life Care Hospital, Varanasi. Of course, she has completed her MRCOG and FCCS. We welcome you, Dr. Vanita. And Dr. Namita Bajpai, who is also from I think, I can't see her society actually. Yes.
Greater Noida, ma'am.
Okay, Greater Noida. So Namita, I'm sorry, I could not see the name of your society, but we have communicated with you personally, and we are very happy to have you there. You are also the working in the Department of OBS-GYN consultant at, and you are also you have graduated from, I think, Nandan Bahugan Garhwal University, Srinagar, Uttarakhand. So I think a cosmopolitan person, I would say. Welcome to this webinar. And Madam, next is Dr. Poonam Agrawal, who is the president of Firozabad OBS-GYN Society. Of course, the lots of papers and publications to her credit. We welcome you, Dr. Poonam. With this, we straightway go ahead with our panel discussion. And I think we try to make the discussion as quick and crisp as possible. I would just ask all of you whether you can see my screen and you can hear me. Please let me know. Can you see the screen?
Yes, ma'am, we can.
Yes. So, welcome all of you. I'm sure all of you know what we are going to discuss here today. The discussion is on near miss. Near miss. That means yeah, this terminology we have borrowed from the airlines industry, where two planes are almost overlapping and about to crash, but this tells you the severity or the gravity of the situation and the urgency of intervention it demands. And near miss case scenarios in obstetrics means a pregnant or a recently delivered woman who would have otherwise, died had it not been the good care and the luck on her side. So we obstetricians have that privilege that we are the savior. This, because of the changing demography of our obstetric population, we are facing these situations more and more frequently because the prevalence is also risen and the spectrum has broadened. The reasons all of you know this. And that is why we are talking about the maternal mortality rate all the time. So friends, it is not only the statistics, not the figures and numbers, rates and ratios, but these are women. They have their faces. And we obstetricians have seen these faces in the face of their distress, despair, and agony. And these keep on haunting our dreams. That is what it has been expressed by the past president of FICO, Dr. Muhammad Fatala. Similarly, Dr. Ayn Donald has said that looking back over along the clinical times, one tends to forget the failures and we just take it for granted the success. But it is the failure that stands out like keloids, reminding us all the time and warning to the others. So, friends, without much ado, as I have already said, that we are having these problems more frequently and the more with the more broader spectrum because of the changing demography. And every case is a new learning for you. So friends, never stop learning because life never stops teaching you. So without much ado, we go ahead straightway with the discussion and we start with the first panelist, Dr. Apeksha. We have this second Gravida with previous cesarean section, last childbirth only 1.5 years back. She comes to you with 7 days overdue. You do her urine pregnancy test. It is positive. She asks you for medical abortion. So maybe that's it is not you, but some other doctor who has prescribed it and called her after for follow up after 7 days. She gets only spotting, but giddiness off and on. And maybe on 6th day around 11 p.m., she's brought to you by the relatives in a collapse condition. What do you think when you examine she's got tachycardia, hypertension, BP is only 70, she's severely pale. What is your differential diagnosis here? What investigations would you like to do to confirm? Yes.
This patient is clearly tachycardia hypotensive, so she is clearly in shock with pallor 2+, history of UPT positive, overdue. She is definitely in shock, hypovolemic, hemorrhagic kind of shock because pallor is there, and with a history of MTP pill intake without a ultrasound. So this could be a case of ectopic, and that could have ruptured and led to this thing. To confirm that, I would like to do an ultrasound for sure, along with routine investigations to know her clinical condition, and of course, after stabilizing her with some fluid channel.
Yeah. So what is the management for this patient?
For management, first thing is, because she is hypotensive, she needs immediate
Yeah, you
fluid
said that you will stabilize her, but what is the definitive management for this patient?
Ultrasound done, and if it is confirming an ectopic pregnancy, then she needs surgery, maybe laparoscopy or open surgery, whatever is available at that point. But she needs definitive management by surgery.
Okay, so you have said it once again that whether it's a you will go for laparotomy or laparoscopy.
This patient is not very stable, but if she responds well to fluid management, we have blood in hand, and with our expertise, if we feel confident to do it a quick laparoscopy, we can do it that also. And if someone is not that confident, they can go for open laparotomy also, because priority is saving patient's life. It's not about a scopy or laparotomy.
Yes. So whatever infrastructure you have and whatever procedure you are comfortable or you have the expertise with, that should be processed. Now you let me know that she's a case of ruptured ectopic. It's not only ectopic. What will be the definitive management? What type of surgery you want to do? Whether you want to conserve the tube or you want to go ahead with salpingectomy?
If it is already a ruptured tube, it's really difficult to save the tube at that time, because if it is ruptured and already there is a large TO mass,
I
so
would say no point in saving, right?
yeah, the tube is not salvageable at that point.
Okay, so you will go for salpingectomy. So whatever, you have to stabilize the patient, give her aggressive fluid resuscitation, give her blood component, whatever is required, and you go for the definitive surgical management, whether it is a open laparotomy or laparoscopy, whether it is a salpingectomy or a conservative surgery. If at all you find it is only the tubal abortion, and then of course it is not a ruptured ectopic, then only you have to go for conservative surgery. What are the learning points? What has gone wrong, and how do you want to
Never ever give a medical abortion without an ultrasound done.
Okay. Is
That
it mandatory by law?
Although it is not mandatory by law, but practically, this is what we feel it should be done.
You should say it clear and loud. You are right. That even though it is not mandatory by law, for the safety of the patient and for safety of yourself, it is recommended that you go for ultrasound before prescribing any MTPs, right? And you have to do counseling of this patient very well, and you have to write an informed written consent of all these points, that if at all you find that something goes wrong, you find these are the adverse symptoms like giddiness, fainting attacks, you must report to the doctor at the earliest. Maybe even the profuse bleeding. Sometimes, you may feel that this patient is not, she just coming up with excessive bleeding. That is also one possibility that can happen, right?
Yes.
Okay. So we go ahead with this is what is yeah. So we go ahead with the second
Can I
case
add
now.
something here, Dr. Sneha?
Yeah, please.
As we know, for the medical method of abortion, we don't admit the patient. But on paper, she should be admitted, she should stay nearby, and we have to explain the warning sign. So whatever the problem she has, she should come immediately to the hospital rather than after rupture ectopic. So we have to counsel and should be given in a written consent, not on the from market she can take and take the drug. That is not safe for these type of patients.
Right. That is why you are very right, madam, and that is why we have said that it should be counseled well, and informed written consent should be taken from the patient, and everything has to be explained well. That is what we have said actually, and you are right that it should not be a over the counter prescription. The point very well taken, madam. So
there is a admission form of these type of patients.
In
When
fact,
we are giving medical method,
in fact,
admission form is also available.
Yes, in fact, we have a consent form which mentions that for 14 days, the patient has to be in touch with the doctor, right? So that is what is to be explained and to be taken as a written informed consent. Okay, so we have lots of interesting cases ahead, and we go quickly with the second case now. So we have this 36-year-old, lady who is conceived after IUI. Her husband is working in Dubai. She is staying in a village, but because this is a precious pregnancy, she comes to you regularly for antenatal checkup at up to 24 weeks. You find that, she is told that everything is normal and she is lost to follow. So at about 34 weeks, she reports to a primary healthcare center with pedal edema. At PHC, the blood pressure is 176 by 116, and the rest investigations then can we include the other people, I think, who are not talking. So this patient is, missed for follow-up. Her BP is very high now, 176 by 116. And then, of course, very little investigations are done there. So they found that it is normal. So this PHC medical officer gives only tablet Nicardia retard, that is nifedipine retard, and he advises admission, counsel for the possibility of early delivery. So this lady did not get admitted, even she did not report to the higher center. Reported to the higher centers almost 1.5 to 2 days later. Okay, that is sub-district hospital. So they had there also the blood pressure, in spite of nifedipine retard, it is still the same, around 168 by 110. Okay, so they added tablet labetalol and they started with magnesium sulfate. Because they had the anesthetist there, they also went for cesarean section, and 1.8 kg live female baby was delivered. In spite of nifedipine retard, tablet labetalol, magnesium sulfate, the PP was still in the range of 140 to 180, 100 to 110. So on second day, almost 30 hours later, this patient became suddenly severely breathless and started coughing. She developed severe bradycardia, tachycardia. Her blood pressure shot up to 220, 118. Oxygen saturation fell down to 70%. Her chest was full of wheeze. So, Dr. Indulata, what is your different diagnosis and how will you tackle this patient?
Basically, the history of the patient is showing that there is elderly preemie, there is high blood pressure, there is proteinuria.
No, we would discuss the differential diagnosis first. We will go ahead with the other things later on. What is your immediate diagnosis for this patient?
In this case, the immediate diagnosis of this patient is pulmonary edema due to severe preeclampsia.
Right. So, any differential diagnosis you want to have for this patient?
Yes, we can have pulmonary thromboembolism or any cases of peripartum cardiomyopathy just after delivery of the fetus, or any acute exacerbation of any, if there is any history of asthma, then there could be a acute exacerbation, and pneumonia due to sepsis. If patient might have pneumonia, then she could present in this condition with breathlessness and restlessness with cough. But
now you tell me, how do you manage this patient?
So in this patient is already received MAGSELF and patient already delivered. So in this patient, we have to start with the ABC, the airway, breathing, and circulation.
Doesn't matter whether she is delivered or no, because she is in acute catastrophe. But then we have to start the emergency management. So how will you do that?
So patient is already delivered. So we have to go by we have to keep this patient in propped up position, immediate oxygen inhalation by straightway 8 liter oxygen, 100% oxygen should be given by an RB mask. And we have to give the high doses of diuretics to decrease the fluid overload in the lungs. That is 40 to 80 milligram of furosemide. And with this, we can go for investigation also, like X-ray chest, in which we can see the pulmonary infiltrates and the alveolar haziness and around curly B lines, etc. So
no, investigations we will talk later. You have said it that you have to give 100% oxygenation, you have to give the diuretics. It's okay, but what about the 220, 118 blood pressure?
We have to give the intravenous, because at this blood pressure we will give intravenous antihypertensive therapy in form of
how much?
Hydrazine. In this case, because patient is in pulmonary edema, so we would like to give hydrazine, injectable hydrazine, or nitroglycerin.
Right.
Because in these cases we avoid to give labetalol. Labetalol.
Yes. People who have access to hydrazine and of course NTG, definitely should go ahead with the preferring these drugs. But if at all you don't have, you may have to go ahead with the IV labetalol also, because here it is hypertensive emergency, right?
Yes.
Okay. Okay. Now this patient was, by the time, of course, you will not manage everything. The moment you see such patient, you will shout for help.
Yeah.
Okay.
First shout
And
of
you get all your, all your team, not only your staff, your assistant doctors, but also the anesthetist, physician trained cardiologist or intensivist, whosoever you can grab, so you can call them. And then by the time you do this primary management, your intensivist or physician has reached, or your anesthetist has reached. So this anesthetist, is also helping you in managing. By the time the patient was getting assisted respiration by ambuvac and the patient was shifted to ICU, this patient developed cardiac arrest. Okay.
Yes.
So Dr. Shuchi, this patient was then managed, of course, in ICU, and then, of course, she reverted to normal. She was, revived after 1 hour, the spontaneous respiration with the blood pressure of 100/64. But for this patient, what do you feel that, as she has already talked about what is pulmonary edema and how do you do this ABCD, she has already discussed all this. Okay, you have to give her proper position, go for oxygenation, give diuretics, give antihypertensives, and then you go look for, now once you try and stabilize this patient, then you look for the cause. Maybe you take out X-ray chest, maybe bedside echo also, you send the cardiac enzymes, you don't know whether it is myocardial infarction also can be, because if the chest is full, you will give a nebulizer, right? Nebulization also is required. You may give her steroids if at all you don't feel that the BP is coming out, maybe some sort of reaction also. So considering everything, the CVP monitoring, invasive monitoring, you will stabilize this patient. And now, of course, you will monitor this patient and pull her out of this situation. But can you tell me for this patient, what has gone wrong right from the beginning? I have given you the history very well. Please go ahead.
First of all, madam, there should be teamwork. We have to work in a multidisciplinary team approach. We should be called for help and all the.
Dr. Shuchi, I'm asking you, what has gone wrong for this patient?
Starting
Teamwork
from
and all
beginning.
these things will come when she becomes moribund, when she lands up into problem. But right from beginning, from the history, can you make out that she is a case high risk?
Yeah. First of all, there is some lacune in ANC care as well. She should have been taking the thorough ANC care starting from beginning. Then she came right away. No, actually she was having some care till 24 weeks, and then she suddenly turned up at 34 weeks. So there was lack of some weeks in between. Then she should have been referred to tertiary center that time. When the BP was there was severe PIH. Hello.
Yes. Anybody else? The other panelists I would like to add. I would like to ask you. Right.
And then
pregnancy. Other panelists I would like to ask. Anything else from the history you want to point out? It's not that why she late and why all these things. You have to know from the history. I mean, as a managing obstetrician, what we
First
She's
antihypertensive given
elderly
to her
primary
was
also. Yeah.
Anybody else? I can see Indulata Sahu, and of course I can see Dr. Mamata Singh, Apeksha Vishnoi, Dr. Poonam Agrawal. Anybody?
She was started on nifedipine as the first choice of antihypertensive.
Before that, all of you are right, but I would say we have to go systematically, not to miss, and that's the reason I'm asking you right from the history what all you have missed. You missed the obstetrician who has managed.
As this patient is elderly primary and living in a village, so we have to counsel this patient that she has to come for regular ANC checkup.
My dear, she has come to us very regularly up to 24 weeks. It is we have made the mistake. So I want to know what mistake has the obstetrician made.
because she missed her regular checkup in between 20.
Ma'am, uterine artery Doppler.
Very good, Poonam. You are coming closer. Yes.
Yeah.
So I would tell you that the prediction part is missed. So now I
Yes,
give you
ma'am.
again.
Our madam, BMI
Old
is not
woman.
known here. BMI, any family history, that's all.
36-year-old woman conceived with IUI.
Yes,
You know,
itself high risk.
yes, so she is high risk and you have to go for early prediction. Nowadays, it's not only high risk, it is universal screening for everything. Okay, so at 11 to 13 weeks, this lady should have been screened for NT scan, the uterine artery pulsatility index, of course, the cervical length, everything, and the SFLT and PLGFs.
Yes.
The PLGF and of course the SFLT. Okay, all these predictors of hypertensive disorders of pregnancy. And before that, the maternal characteristics tells you about the HDP gestosis score. If she has, all these parameters, if she is high risk, then you have to start with low dose aspirin and high dose calcium. So right from early pregnancy, if you had started her on this, then maybe she had not developed the HDP to this severity. HDP is never preventable, but at least you don't develop it into that severity. Okay, so that is one. Secondly, when she was diagnosed and she was taken to the PHC 176 by 116, what is your opinion about the antihypertensives and the management there?
This patient, actually, this blood pressure was taken at PSC. So this patient should be referred to the higher center for further management.
And there only we should have given IV Lobet. And
Yes.
then prophylactic Maxelf also
could
have been given. But at
So-
least IV Lobet should have been given.
Yes, but why do you all agree that even the government of India is recommending that if not the full loading dose, but at least the injectable, the intramuscular dose of magnesium sulfate should be given even at periphery. That is what is recommended. If not, this PHC should have, referred. That is called as effective referral. This PHC medical officer should have accompanied this patient in the ambulance at the higher center. Right? Yes. And of course, nifedipine retard was not the drug to be started that time. Correct? So that was one more mistake. Next, when this patient goes to the next level, the sub-district hospital, there also they have committed the same mistake. Right? They started with tablet labetalol when the BP was persistent to 168/110, right? 168/110 is again a severe hypertension. Okay, so everything has gone wrong. The antihypertensives have gone wrong. And then, of course, when you have the facilities of anesthetists, everybody, you have to give the injectable labetalol or maybe oral nifedipine, whatever you feel that a nifedipine orange color capsule, which is a quick acting or fast acting nifedipine, right? Not the retard preparation, correct? And of course, with this, then once the baby is delivered, and then you have so many things. When the patient was taken up for cesarean section, all of you know that, they give preload. The fluids are given fixed volume. It is given as very fast infusion, correct? Okay, so once the baby is delivered, you should not give Mittergine, and then of course, in fact, you may have to give Lasix then and there only, so that, whatever excess fluid was there could have, drained out, and then we could have prevented it. Now this patient, all of you can make out here that every step she has gone wrong, and that is why she has landed up into this complication. Correct? So this was a totally preventable situation. Though now this has become a near miss, actually this patient could have been, even prevented for landing up into this complication.
Yes.
Okay,
Yes, sure.
so very well discussed. We go ahead with the next case now, Dr. Mamta Singh. This is a case for you. We have this young lady, primary gravida with 9 months amenorrhea. She comes to you at around 11 p.m. in your hospital, and she gives you the history that she was admitted in some small nursing home maybe a few hours back in the afternoon, where she has very strong labor pains, and because she was not progressing, so the bladder was catheterized. She was to be taken for cesarean section. Bladder was catheterized, there is no urine. Then they asked her the history retrospectively. Almost for last 12 hours she has not passed urine. Okay, and then they thought there's something wrong. Then they shifted to the tertiary care center, where you examine and you find that she's got severe pain. Pulse rate is 110, BP 110/70. Contractions are so severe that there is no relaxation in between. It is severe in intensity. Fetal heart going down to 100 to 120. The dilatation, I'm sorry, it is not 7 centimeter. It is 2 centimeter only. The membranes are absent and you're getting blackish colored fluid there. Station is 0. So what is your diagnosis here from this history?
Good evening, ma'am. Can you hear me?
Yes, definitely.
So, ma'am, on the basis of the history and the findings given below in this case, this is a case of abruptio placenta with DIC. Patient is in the DIC.
This is the case of abruptio. That is what the clinical diagnosis was.
Yes.
And then when the investigations were done, HB8, platelet 1 lakh,
yes.
APTT was prolonged, FDP was present, and fibrinogen was very low.
Is also low.
That tells you that she's gone
indicates-
into, So what are all the aspects to be managed and how do you manage that?
So, ma'am, the management depend upon the correction of DIC and correct the underlying cause of DIC and C-section.
But then, Dr. Mamata, don't you feel that, she's got fetal distress? By the time you arrange everything, the baby will die. So do you want to take care of cesarean section at the earliest, or you wait for the blood and blood components?
No, ma'am. I think we should shift the patient for C-section, and meanwhile, we should arrange all the cryoprecipitate, fresh frozen plasma, platelets, and blood also.
Okay. So we just hold on. Can we have the other panelists' opinion? Should we take her up for cesarean section immediately, or should we wait for the blood components to get ready? Should we, Dr. Apeksha, Dr. Indulata? Yes.
Ma'am, stabilization and shifting should go hand in hand. We have to deliver the baby because
stabilization and shifting, I agree. But what about blood and blood components? The coagulopathy aspect.
Yeah.
Because you have so many aspects. She is not progressing. She's got abruptio, she's got DIC, she's got fetal distress, she's into hemorrhagic shock, she's landing up into acute renal failure.
Ma'am, we have to arrange PRBs,
Ma'am, we will do
FFPs. Yeah. Platelets, FFP, and PRBCs, all the 3 components.
I don't think, 1 lakh, the platelets.
Yeah, but still, at least blood and
Ma'am, we will do fluid resuscitation first.
Yes.
Ma'am, we will do fluid resuscitation first, and in the meanwhile, when we will arrange for the blood and blood components, then we will shift for cesarean section. Cesarean section preparation will be hand to hand, so that we can do cesarean section. But at the time of cesarean, if we are due to the coagulopathy, if we are having a massive blood loss, then it will be very tragic and difficult to manage. So first of all, we will do fluid resuscitation, and after the availability of blood products, then we will do cesarean section.
But we should also we should keep in mind, madam, that she is having almost anuria. So just giving fluids won't help. We have to actually correct the DIC and terminate pregnancy.
No, we don't agree with this. Anybody see, basically why she has landed up into anuria, that is because of hypovolemia and hypoperfusion of the knee. The moment you correct the aggressive fluid resuscitation, the hypovolemia is corrected, the GFR improves and anuria part improves. But the coagulation failure remains.
Yeah, we can start with IV fluids, but then blood products have to reach quickly. That's what I mean to
That is what I'm saying. Otherwise, you will not. Otherwise, you will not take her up for cesarean section. What the optimum is, you have to do everything simultaneously. That is what is the answer expected. So you aggressively resuscitate the mother with fluid. You arrange for the operation theater, arrange for the blood components. at least you make sure that the blood components are reaching in time, and by the time you may just, start with the cesarean preparation. The moment you find that the blood components have reached, you will infuse them fast with, of course, the invasive monitoring, which already you have started because, you have done aggressive fluid resuscitation. So that time itself, you have to go for the CVP monitoring, that is invasive monitoring. And then you go ahead with the cesarean section. Now, what precautions you take for this patient, especially? You have infused her with blood and blood components. You have adequate blood and blood components. During the procedure, what precautions you will take? What precautions? Because this is the patient who has got APH and DIC will bleed also. She will also land up into BPH. Correct? Is it not? The abruptio placentae, it may have, the myometrial irritation, the cuvalier uterus, which becomes very atonic sometimes. So what precautions you take?
We will be ready to do the either for the conservative surgery because she is priming gravida, I think. So we will be ready to do the compressive sutures or B-link sutures.
Why not talk about medications first?
Preventive
Be prepared for PPH.
Be prepared.
So what,
ma'am, actually in this case there are higher chances of PPH also.
You want to use for this patient?
Ma'am, oxytocin.
In this case,
of course, you want to prevent the atonic PPH.
Carbetocin.
Yes, PPH.
Carbetocin.
We can
Yes,
use
perfect.
carbetocin, oxytocin, prostaglandins.
Yes, because she is hypertensive, so you will try to avoid methergine, correct?
Yes.
But
Yes.
if at all you find that in spite of giving carbetocin, and maybe you are still facing that, there's absolutely no tone, then don't hesitate in giving methergine, because you can manage the hypertension, but managing the PPH or, becomes very, very difficult, right? So if needed, you have to give methergine. Methergine is necessary in some of the cases. Okay, with carbetocin, if you can manage, well and good. If not, you can give methergine. And then, of course, whenever you feel that, she may land up into overload, she may go into pulmonary edema, you always have Lasix furosemide at your disposal, correct? Okay, so now when you manage this patient with all these oxytocics, and then, of course, you have to manage the hypovolemia. So once you correct the hypovolemia, your renal ischemia will improve, your urine output will improve, and of course, you can prevent this patient going into irreversible renal failure. And definitely, with all these blood and blood components, you will see to it that the coagulopathy is also treated, and then you will deliver her by cesarean section. How do you manage this coagulopathy? What is the blood component required for such a patient, and how do you infuse them, transfuse them?
Ma'am, for this patient, we need fresh frozen plasma, platelets, platelet arrangement, whole blood, PRBC, and cryoprecipitate. These four things we need in these cases.
Yeah, 1:1. That is what
1:1.
And ma'am.
Yeah. Yes. Anything else you want to add? What should be your target of therapy? Your blood pressure should be how much, and at the earliest your urine output. What is the targets of the therapy?
Mean arterial pressure above 65 should be the target.
Okay. And the systolic blood pressure above 90?
Systolic of 90 and mean arterial.
Okay.
Urine at least 30 ml per hour.
Yeah. So do we have Madam SP Javaswar? Can we have few comments from you?
This is the real crisis.
Yes. Yeah.
This is the condition which is really patient is in the crisis along with the obstetrician also. Because at the same time, we have to manage the anuria, coagulopathy, and we have to deliver the patient also. In this situation, we have to correct the coagulopathy, try to deliver the patient vaginally. Because in abruptio placentae, the vaginal delivery is preferable. Unless there is an obstetrical indication. If the fetus is alive, to save the fetus, we can go for the cesarean. Otherwise,
So
the vaginal
what
delivery
is
is
the
the best one.
treatment for our patient when you have 2 centimeter dilatation with fetal distress? So naturally,
in that,
for
this is
patient,
the obstetrical indication for cesarean section. So we have to take out the baby, and with this, we need lots of oxytocics, not methergine, to prevent, and sometimes we need even balloon tamponade also to prevent the bleeding. So, and along with that, loss of blood, and as we already mentioned, the ratio should be 1:1:1. And about the anuria can be corrected after giving the fluid, but if it is not, then sometimes patient needs some short time of dialysis also.
Yes, once you correct the hypovolemia and you give, what is called as forced diuresis or the fluid challenge test, with that Lasix, IV fluids adequate to correct the hypovolemia, followed by the injectable diuretics, definitely, treats the anuria when it is in a phase of reversible acute renal failure. That is what.
Otherwise,
And we
sometimes
have
patient
to
needs
act.
dialysis also.
Yes, we have to act in that place. As far as the prophylaxis for PPH or prevention or
जिधर
preparedness, we
उधर
say.
क्रॉस करने का ना उधर होता है.
Hello. I think Dr. Poonam is driving, is it?
Yes, ma'am. Yes, ma'am.
Yeah, so it's not about which oxytocin, it is the oxytocin which is effective. And when you have such a crisis where your patient is already, a tonic PPH, where she already has DIC, you don't have to think about which oxytocin. You don't have to think about even lethargy. That is what is the recommendation. And that's a very reason, even recently, the carbetocin is the preferred drug of choice. But definitely, if it doesn't work, then not only methagen, but even the prostaglandins, maybe the tablets which are kept per rectally, or even the injection carboprest is recommended, because you can't, you can't afford to have a PPH in a patient of DIC, correct? So we move ahead with the next case now, Dr. Vanita. This is for you, Dr. Vanita.
Yes, ma'am.
Dr. Vanita, yes. Hello, Dr. Vanita. So we have this patient, para 1 previous seizure, and the male child is only 1 year old. So now she comes to you during her 6 months of pregnancy for the first time, because her husband is transferred to your place. After reaching the hospital, she gives you history of bleeding. She comes to your hospital, now the bleeding has stopped. When you inquire her, then she says, yes, there was a, early pregnancy spotting as well. And there the ultrasound was done, which was suggestive of low-lying placenta. Today, you do her ultrasound at 26 weeks. You find that the placenta is low-lying, there is absent RP leg, and the anomaly scan is normal. At 30 weeks, again, she starts bleeding at home significantly, stops in between when she comes to your hospital. So you feel that you get her investigated. Let us see whether we can wait for some more time. So she, starts bleeding profusely in your hospital and collapses. What is your diagnosis here, and how do you manage this patient?
Ma'am, according to clinical history, she is a case of gravida 2 para 1 live 1 with previous LSCS at 30 weeks with placenta previa with severe antepartum hemorrhage in hemorrhagic shock. The patient is in hemorrhagic shock. According to the previous ultrasound, she is a case
One more
of.
thing, I would stop you here.
Yeah.
Is it only placenta previa or something
No,
else?
ma'am. I am adding it.
Okay.
She is having history of previous one LACS with persistent low-lying placenta since the early pregnancy till date. So she is high risk for placenta accreta. But
that is okay. But you are having the clear-cut findings on ultrasound.
Yeah,
Absent
on ultrasound at 26 weeks, there is absence of retroplacental legs. But only one finding is there. Other findings are missing. Whether there is myometrial thickness is missing or not, it is less than 1 mm or not. Other findings are missing.
So I would ask you, what are the features of placenta accreta on ultrasound?
Ma'am, on placenta accreta with Doppler, there will be finding of retroplacental legs. Multiple placental lacunae are there. There is absence of intramyometrial bladder myometrial zone. The thinning of myometrium less than 1 mm, and indentation of myometrium inside placenta inside the bladder. If there is a accreta along with percreta.
Okay.
Yes, ma'am.
So basically, there are multiple vessels running across the surface of the uterus and the bladder. Okay, that is also one more additional finding. But suppose your ultrasonologist is not very much trained. then if he is giving you the hint at least that the RP leg
Yes,
is
ma'am.
absent, you have to have
MRI can be done.
that
Yeah,
is
yeah.
no, you are coming one more controversial point. Somebody said
Yes, ma'am.
MRI. Can we know is there I mean, is it a must? And what is how do you compare MRI
No.
and ultrasound?
There is dilemma between
No.
whether ultrasound is best or MRI is best, but the ultrasound Doppler finding are much more informative, as likely as that of the placenta accreta is concerned. But in cases of placenta percreta, if you want to know the invasion inside the bladder or inside the bowel,
Depth
then
of
we
invasion.
should go for MRI.
Right.
MRI.
So
And then
for
expertise also there.
yes, for the expert, that is what I'm going to say. For a good resolution ultrasonography machine with good expertise of the sonologist, skilled expertise sonologist, definitely the accuracy of ultrasound sonography and MRI is comparable. Okay.
Yes.
Only in cases of extremely
Percreta.
posterior placenta, secondly with morbid obesity, and of course where you want to plan the conservative surgery to know the placental mapping, what we call it as, to know the depth of invasion of the placenta, there you have to go for MRI, right?
MRI.
So
Yes,
this patient, you have already said it is placenta previa accreta. Now for this patient who is collapsed, you have to go ahead with resuscitation. All of you
Yes,
know
ma'am.
the
Like
resuscitation very well.
as
But now I
previously
ask
did
you,
before.
yes, now I ask you, because she's collapsed now in front of you, what is your plan of management?
Ma'am, in this patient, we have to go with a team and parallel approach. We have to resuscitate the mother first. Second, we have to arrange for immediate cesarean delivery. We have to see for fetal viability there or not. We have to arrange for a neonatologist along with, and go for a delivery along with the blood and availability of blood and blood product.
Yes. Where is the part of counseling? What
Ma'am,
the
in the
relatives should
counseling,
know something.
yes, in the parallel approach, we have to go and talk to the tenants first that the patient is having placenta previa accreta. In case we have chance that we have to go for cesarean hysterectomy along with the cesarean section, because
Before that, I interrupt you here. Before that, 30 weeks you are
yeah, ma'am,
telling them
prematurity
to
along with that.
go for cesarean section and
Yes,
maybe
ma'am.
but they will ask you, what about the baby, doctor?
Yes,
Then
ma'am. I already said that we have
no,
to
that
arrange
is
neonatologist.
not included, my dear Vanita.
Yes, ma'am.
You have to
Yes,
tell them. She will say, then you are doing Caesar. That means you are saving the baby, right?
yes.
So
Ma'am,
that
we
you
have
have
to
to
go for
explain.
fetal assessment first. If the baby is alive, then we have to arrange for neonatologist. We have to counsel the attendants that the baby is premature, 30 weeks. Then
Right.
he or she will need the NICU
Yeah,
and
but there
support.
can be problems also. We cannot assure the survival.
Yes,
Here,
yes, ma'am.
this procedure is for
Mother
the
saving.
saving the
Mother
mother.
saving.
Mother
Okay.
first. Yes, ma'am.
Yes, for saving the mother. We are trying to do our best. We are trying to save both, but it can happen that the baby may land up into problem because it's already preterm, and it is also there is excessive blood loss also. So all these factors considered, we can have problems with the baby, but definitely we are trying our best to save the mother, because the mother is also going to have problems. It's not
Yes,
so
ma'am.
simple that you do Caesar and everything is
Mother
all
is
right.
yes,
Yes.
ma'am.
So that is where the role of counseling and informed consent comes. Okay, so Dr. Vanita, we continue with you. What will you talk to the patient, the relatives about the procedure, and what precautions you want to, I would say, whom all do you want in your team for the
Ma'am,
surgery?
as the patient is in hemorrhagic shock and pregnant, we want a good anesthetist, good critical care physician backup, ICU backup. Then we want blood bank services, that we want blood and blood products. Second, we want a good neonatologist to, if the baby fetus is alive, to save the fetus, we want a good neonatologist and good operative theater team along with me.
Okay.
And if the patient will land up into
Anybody else
severe
you want?
BPH,
Anybody
yes,
Madam,
else
ma'am.
senior
If the
obstetrician
madam, if
along
patient
with
is, yes,
urologist.
ma'am.
Urologist
Yes, ma'am.
also need.
Urologist
Yes,
to
ma'am. Yes,
take
ma'am.
care of bladder if there is any invasion in the bladder.
Yes, ma'am.
Okay.
We
Is
need.
it only to take care of the bladder or something else? One is, you may tear the bladder, you may injure the bladder. Some people,
Yes, ma'am.
some of the cases of percita, you may have to actually cut the bladder deliberately, right?
Yes, ma'am.
Yeah,
Yeah.
that is called as deliberate cystostomy. And then you have to
Testosterone.
go through.
Yeah.
Yeah. Okay. So it's not only to tackle the bladder, because even we can tackle it, but best way that, the person who is supposed to do should be present. That is one, that bladder injury. But second is, sometimes you may need the stenting of the ureters, If
Yes,
you
ma'am.
have percrita, then it is very, very difficult to, avoid the ureters coming into the your field, right? So everything is in a mess. So you may have to go for stenting pre-operatively. Anybody else you want? So here you may have the general surgeon, the urosurgeon, or the oncosurgeon. Means only one of these three,
One of
whosoever
them.
is available. Right.
Ma'am,
What else?
if possible, we can have radiologist also can do
Correct.
intervention
Interventional
radiology.
radiologist.
Yeah,
Interventional
beforehand
Yes,
they
ma'am.
radiologist
can
to
go
do
for
Embolism.
uterine artery
UAE.
embolization
Embolization.
and what is called as the aortic balloon.
Aortic
Aortic
balloon.
balloon tamponade.
Yes. So we do have advanced technologies to minimize the blood loss at the
Aortic
surgery.
compression.
And whatever is possible, you will do it before the surgery. Now somebody will discuss about what is the special precautions during the surgery. Special precautions during the surgery. How should be the incision, the abdominal incision, the uterine incision? Yes.
Ma'am,
Yes, ma'am.
vertical
During
abdominal.
the surgery,
Only one person,
we
please.
should avoid placental handling, and we should do
Dr.
by
Poonam,
classical
I would
cesarean.
request you to start from the abdominal incision so
Yes,
that
ma'am.
everybody understands.
Abdominal incision, ma'am. Vertical incision gives better visual field. So we prefer vertical incision, but it is surgeon's choice. Some people do it by phenestyle also. So
Yes.
after abdominal
Like how
incision,
I do.
we can
I do
do.
it with phenestyle, but you take
But
a
a
liberal
Yes,
liberal
phenestyle.
ma'am.
incision has
Liberal,
to.
but incision
Okay.
should be liberal, whatsoever
Yeah.
it is, because we know that visual field should be good. And after it, when we come to the uterus, we should visualize the blood
Bulging.
vessels which protrude out and seen clearly at the placental side. We should avoid this area, and we should take out the baby from the fresh uterine side. It may be
Classical
classical cesarean.
cesarean.
Off and on, generally it is by classical cesarean section. We take the baby out. We
Yes,
keep the
but
placenta in situ.
that should stop short of the placenta. It should not cut the placenta.
Yes.
Right?
Yes, ma'am.
That is very
Placenta
important.
should not be cut, and the cord should be clamped near the placenta. Placenta should be left in situ, and after it, we should see if we can do PPP procedure. Then we can do it. And if PPP procedure can't be done, then we should move for the hysterectomy. And while proceeding for the hysterectomy, if we have the availability,
What
we
is
should
the
do.
PPP procedure? What is the PPP procedure? Triple P
Ma'am,
procedure.
yes, ma'am. Triple P procedure, we cut the placental margin and above and below, and then the lower margin of the uterus is stitched with the upper fresh margin, and the uterus with placenta is resected.
What are the other two P? There are three P's, no? So what is the other two P? First and foremost, it is placental mapping. Okay.
Yeah.
Placental mapping. You have to know the exact extent and
Exactly.
of the placenta. Okay, how much it has invaded. That is placental mapping. And second P is pelvic devascularization. What is called a stepwise pelvis. You go for uterine, you go for the infundibular pelvis, that is the tubo-ovarian vessels first, and then you go for the exact procedure. And then what you are describing is what is called as patchy myometrial resection. That is the third P. Okay.
Okay, ma'am.
Right. So, yeah, tell me now. So, suppose for this patient, it's because she's a young lady, she's got only one. Now this child, you are not sure, so they insist on the uterus to be there. Then you have to do this procedure.
Yes.
But suppose she starts bleeding profusely. Then what will you do?
Then we will proceed for cesarean hysterectomy, and before cesarean hysterectomy, we will do the aortic compression by our assistant, and then we will proceed so that blood loss will be less, and then
Yes, definitely. So what I'm trying to tell you here, friends, that you have taken the patient in operation theater and you are doing everything, and then when you fail, then you will ask for a consent. That is not the way. When treating the patient, I think somebody needs to. So when you are counseling the patient and taking informed written, this is the patient where you have to, take the informed written consent from planned hysterectomy. That means before the procedure, right? Before the procedure, you have to take the consent. Once you are in the operation theater, you are trying to do everything and then you can't manage, then you go and take the consent. The patient and the relatives will feel that you have done some blunder. That is why now you are landing up into hysterectomy. So in fact, what the evidence says that for management of such patient, the consent has to be informed written consent for the planned hysterectomy, obstetric hysterectomy.
Dr. Sneha, can I add here?
No, just let me finish. I will ask you, madam, whether you try to conserve the uterus and go for a conservative surgery, then definitely you have to, you can try your best. Then, of course, you can tell them. But before that, you have to take a written informed consent. Okay. So, Madam SP Jaiswal, please add.
Thank you, Dr. Sneha, for giving me time. Actually, this is for all, especially for youngsters. So once the patient, there may be two type of patient. One is a diagnosed case of PAS, another is the emergency. So whenever you are suspecting PAS, we have to prepare completely because this patient cannot be dealt at a primary center. It should be done only at the tertiary center with prior explained consent of blood transfusion, hysterectomy, and we need even the critical care unit also. So this should be planned before. And about the consent, we have to be very, very careful because maybe the patient needs conservative surgery also, but depends on. Always give incision after opening the abdomen. If the whole uterus is full of the vessels, always open from the upper segment, take out the baby, clamp the cord, stitch the incision size, and proceed directly for the hysterectomy. And if there is an involvement of bladder and other things, then we need the urologist also. So in this, we need expert obstetrician, expert anesthetist, expert pediatrician, as well as the critical care unit. In that condition, we could able to save the patient. So we have to be prepared mentally. That is very important. Thank you so much.
Yes. Thank you, madam, for your expert comments. And now we go ahead with the next case now. Here we have this, this is the next case we are going for. We have discussed this case. Only one question remains here. Could we prevent this situation? This patient was a registered patient and she presented to you early during pregnancy with history of recurrent warning hemorrhages. You got the diagnosis of, low-lying placenta. Whether there was any role of prophylactic or straightening, Dr. Namita.
So in this, as she was having early times, she was having in early pregnancy, she was having bleeding. So it is better that we detect in early pregnancy only during the 16 to 18 weeks whether it was a low-lying placenta or not, and then we can call her up or follow up her on 20 weeks of gestation for the localization of the placenta. And there is no as such role of prophylactic or tightening since she can have excessive bleeding or she can have placental injury also.
So as per, I think ACOG guideline also says that there is no as such role of prophylactic or tightening, and role of tocolysis. Yes, maybe if we have to just prolong the pregnancy during giving the corticosteroids. If we have to give the corticosteroids, madam, then only we can give the role. There is a role of tocolysis because it has its own complications. It has own contraindications because she will be having tachycardia. So we will not able to differentiate that whether it is she's having because of the bleeding or because of the tocolysis. So yes, we can give only if we have to give her the corticosteroid coverage, but as such there is no role of tocolysis also. And
but tocolysis, okay.
It is
So two
contraindicated,
things.
ma'am, in
That is what I'm no,
Yeah.
not exactly, but I will we will discuss about this. Prophylactic os tightening. Basically, all of you know that cervical cerclage nowadays, had got definite indication. And as per the recommendations, as you say, whether it is SCOG, NICE or COG or FIGO, it has to be short cervix, that is less than 2.5 centimeter, that is 25 millimeter. Just because it is a low-lying placenta, for that purpose, or os tightening or cervical cerclage is never indicated. Okay, and it is absolutely not recommended. As you said, then it leads to trauma, bleeding. That is altogether different. But first and foremost, it is not advisable. It is not recommended by evidence. Secondly, role of tocolysis. Your patient doesn't have contractions.
Yes.
Why you want to give tocolytics?
Depending on the patient's
Your
contraction.
patient doesn't have contractions. She
But as
never
per
had
this patient,
contractions.
yes,
So there is no role of tocolysis.
there is no role in this patient.
Yeah, there is no role. What precautions to be advised? Definitely, what has gone wrong? The major thing, the patient was diagnosed as having low-lying placenta. She was having recurrent warning hemorrhages. She was having low-lying placenta with accreta, even diagnosed at 26 weeks. But in spite of that, she bled and she collapsed. The first and foremost, she should have been hospitalized.
Referred to tertiary
Yes,
Or
she
maybe
should have hospitalized.
first and foremost, the moment you diagnose the patient as placenta accreta spectrum, you refer her to tertiary care center. And then, of course, preferably try to hospitalize her, keep her blood, ample blood pints ready all the time, because you have to tell the patient and the relatives that may whatever you precautions. So what precautions? Not to have intercourse, not to have internal examination, not to go for strenuous exercises, lifting weight, etc., not to travel, okay, and be always in touch with the doctor if at all she is at home, okay, but at home also she has to be like as if she is in the hospital, right? In spite of all this, if at all she bleeds, she can bleed anytime with all the precautions, and nobody can prevent it. That is what is to be explained and written as informed written consent. Okay, so all these things have to be written on the paper, and that is to be explained to her. Then, of course, if this patient doesn't land up into all this problem, then comes the role of steroids, magnesium sulfate, and you try and go for elective cesarean section. Don't land up into emergency, because during this period you have the senior obstetricians, senior anesthetists, and even the blood and blood bank, everything at your disposal. All right. So go for elective procedure. Don't land up into emergency procedure. So that is what is the message from this case. I'm sorry. Okay. So can you see the slide? So these are the Grintop guidelines saying that whenever you do ultrasound at 16 weeks, you find the placenta is 2 centimeters away from the internal os, you label it as low-lying placenta, keep a watch, monitoring further ultrasound reports, and of course, you have to see that whether it is the RP leg or the sonolucent zone is present or absent. That is what you have to look for. And then, of course, this patient, your only aim should be to prolong this pregnancy, take this ahead to at least 34 weeks. I mean, 37 weeks preferably, but at least to 34 weeks. See that she doesn't land up into any mishap in between. Keep her blood and blood products reserved all the time. Take the informed written consent all the time. You keep it attached to the paper so that, you don't wait for the, consent. So now we go ahead with the next case now. We have this 20, we go ahead with the next case now, because we have already discussed what are the special precautions before surgery, during surgery, what, blood and blood products to give, that this all we have discussed already. So we go quickly to the next case. We have this fourth gravida para 1 with 3 abortions, 2 MTPs, 1 missed abortion. Last childbirth 7 years back, and that was a normal delivery. Uneventful antenatal record, ultrasound is normal, fetal growth, everything is fine. Patient is admitted at 11 p.m. in night, that is of course in night active labor. She delivers a healthy baby at 4 a.m. in the morning. Placenta fails to deliver by around 40-45 minutes they waited. Pulse rate is 92, BP is 106/40. Suddenly the patient seems collapse in the pool of blood. Okay. What do you feel is your diagnosis? How do you manage this patient?
Ma'am, as again in this case, she has history of 3 DNCs.
Right.
So she can very well be a case of PASS.
Okay.
And here the placenta has failed to deliver even
Yes.
after
So,
ASL.
but then clinically, she has just failed to expel the placenta. So, what do
Yes.
you label this condition as? Retained placenta.
Yeah, retained placenta, which
Okay.
can
Then
be
how
due
do
to
you go
PASS.
ahead with the management?
Yeah, so similarly, we have to start resuscitation with starting with the IV fluids and blood products. Well, resuscitation should start immediately, and we should do all the PPH PPH therapeutic measures. As in this case,
Okay, so now this patient, when you examine, this was just a history, right? So just a history. This you said it is retained placenta, correct? The placenta
maybe,
was not
yeah.
separated. Somebody was trying to
Inversion. Yeah.
remove it, and then she collapses. So when
Yeah,
you
then we will go for examination.
a uterine fundus is not palpable. The uterus is not palpable. You see there's lots of bleeding, and the huge fleshy mass there, so you can't make out anything. When you do her vaginal examination, you find there is a fleshy mass, but you can't feel where the cervix is, right? So what is your diagnosis now?
Ma'am,
inversion.
Uterine inversion.
Uterine
inversion.
Acute
Yeah.
inversion of uterus.
Yes,
Now
uterus
you
is
tell me,
not
how do
felt.
you manage? How do you manage?
And along with all the resuscitative method as told by Dr. Suchi, we would first this is a case of acute inversion because it presented within 24 hours. So first we will shift the patient in the OT under anesthesia. We will try to reposition the inverted part of the uterus. So in this case, we can do, if we can start our management.
So you shift her to OT if at all you want to do. If it has inverted in front of you, you will try and remove it immediately without anesthesia.
If
Your
it is
patient,
yes, if it is
no rim formation, so we can reintroduce the uterine fundus at that time also.
Correct. In fact, that itself will solve every problem, because so what she's landed into mainly a neurogenic shock. Now she has started bleeding, but it is mainly the neurogenic shock. So the moment you reduce the inversion, the neurogenic shock gets treated on its own. Okay. So this is how. Now what you do? How do you manage? How do you do the reposition?
Ma'am, it can be done vaginally, and if it is failed, then it can be done abdominally.
Yeah, but then
also.
how do you do it vaginally? You discuss first, then we talk about.
First we will try vaginally. We will keep one hand at the suprapubic area, and second hand we will introduce into the vagina. If we can feel the cervical rim, then it is fine. If we could not feel, then we will try to push the projected part, means the fundus of uterus, to push into the abdomen. And the basic funda is the part which comes down lastly will go
inside first.
Inside firstly. Yes.
Actually, the part which is closer to cervix has come last.
Yes.
The fundus is coming first. So naturally, from the cervix, you will push it up, and you will keep your foot up there for some time. You give ultrasonics, And
Tonics
keep your
also.
hand for some time so that you maintain the tone of the uterus. And
Uterus.
then slowly you will try to remove it. But you hold the uterus with your left hand. Okay? You stabilize the uterus with your left
Uterus.
hand like this. Okay? Why do you do that? Why do
To
you?
give the suprapubic pressure to
No,
hold
not
the
pressure.
uterus.
That will come down.
प्रेशर नहीं मैम, उसको होल्ड करने के लिए.
होल्ड करने के लिए, just to stabilize.
That is
Stabilize.
not the stabilize. I say that to stabilize the uterus,
Uterus.
to prevent the recurrence of inversion, right? That is why you keep your hand inside. See like this. Okay? You can see it here. Your hand
Yes,
is inside. You keep it for a few hours. Then suppose if this fails, then of course the post-op management will come to it. But if this fails, then what is this hydrostatic correction? Somebody please quickly take this. We will go ahead. Can anybody take up this? Yes, Madam SP Jeswar? Is she there? Okay, so I will tell you that you prepare a dose of about 3 to 5 liters warm saline. You hang it at the height. You give deep Trendelenburg position to the patient, and with the help of long tubing, you put the nozzle in the posterior fornix, and with your left hand you seal the labia minora. Ask your assistant to start the fluid at a pressure so that the vagina balloons out, and with that pressure the uterine fundus is pushed up. Okay. That is how it is, what is called as the correction with the hydrostatic pressure. Okay.
And ma'am, if still this doesn't help, we can go for abdominal Huntington's procedure.
Yes, there are many procedures. We have tried to avoid. There are Halton's procedure where actually, you have to open the abdomen, pack the bowels, and you go put your hand, one hand in anteriorly, the other hand posteriorly. Try to flip the, uterus up like this with both.
Round ligaments.
Yes, and then this is the procedure where you are Halton's procedure, flipping it up so that you raise the fundus with the hands only. Okay, and the other one is the Huntington's procedure, where you, with the help of non-traumatic forceps, not Ellis, I will not agree to this, but OBSTETRICS or such kind of forceps, non-traumatic forceps, you will gradually hold the
round ligament.
round ligaments, which is a tougher structure little, and then gradually you will try to follow up and take the fundus up, and then you relax. Okay, then you go the uterotonics.
Ma'am, constriction ring we can give posterior vertical incision.
Right, so that is called as
Huntington's.
Yeah, so so you cut it. Before that, there is one more, that you manually dilate the cervical, take the fundus up, and then you start the uterotonics. If you can't do this, then you negotiate this. You cut it, incise it, reduce the, make the fundus go up this constriction ring, and then you close it. Okay. And of course, there are some more, with the help of kiwi cup, you try to, use it, negative suction and all these things. Okay. So this is the last case where actually we want to just give a message to you that we have this grand multipara admitted to emergency ward. She has had one previous normal vaginal delivery, and this time she came to you with, obstructed labor. So she, because she was in prolonged obstructed labor with fetal distress, the cesarean section was done. It was uneventful. There was little extension to one side, but there was no bleeding, and the extension was taken care well. It was repaired well. In spite of all this, things were well. And after an hour or so, she landed up into, excessive sweating, rapid thready pulse, BP became 80. This abdomen is soft, absolutely no signs of bleeding. There's no bleeding externally. So what is your diagnosis? How will you manage it, Dr. Vanita? Yes, Dr. Vanita. Do we have Dr. Vanita here? Anybody can take up this. We will just sum up this case fast. Dr. Sulata Sahu, we have not heard you since some time. If you want to take up, please go ahead. Dr. Namita.
Yes, ma'am.
Yes.
So, ma'am, since she had pulse 110, 110 and BP 130 by 80 with maternal exhaustion, and the baby weight was 4 kg.
Yeah.
So we can consider her case of diabetes.
Very good.
Since in this it says that her blood pressure is 80 and pulse is steady, so and of course she is having disturbed respiration and confused look, so she is a case, maybe a case of diabetic ketoacidosis.
So first and foremost, your clinical diagnosis is non-hemorrhagic shock.
Yes, non-hemorrhagic shock.
Yes.
Definitely, she is not a hemorrhagic shock.
So of course, she's already operated. You are giving her fluids fast, but which fluids you have to know, and that is why by the time somebody is giving fluids and calling somebody, you just do her, with the help of glucometer, you do her sugars, and that comes more than 600, and you do her urine strips, that is ketones 3+4+. Okay, so very easy diagnosis, and then of course all of you know how to manage everything. I'm not going to discuss. My only message
Suppose,
is
madam, blood sugar comes normal, then
for this case, for this case it was diabetic ketoacidosis. Now you tell me if the blood sugar comes normal. What is the reason?
If the blood
Electrolyte imbalance.
Electrolyte balance could be one of the reason. So we will be balancing we will balance electro imbalance, will balance it.
लेकिन मैम blood pressure 80 हो गया ना इसमें शायद, हाँ.
Yes, but it will not be only electrolyte balance. It is
negative
balance.
There can be component of some hemorrhagic shock.
Embolism,
We
in
have to
differential
be
diagnosis, we
careful.
can take it as a pulmonary embolism.
Embolism will not present like this. Embolism will present, very catastrophic. The moment you see it, now it is 190, 70 and absent. Okay. So that fast it goes, and the patient becomes cynos, this, that, so all these signs. Here, if at all you are saying that there is absolutely nothing else and even the sugar is normal, hemoglobin is even normal, the only reason can be negative fluid balance. Okay. This is what is our experience. It happens many a times, sometimes in operated patients, sometimes maybe she's NBM for maybe 12 hours or so, she's in labor, she's dehydrated, and then when you give conservative fluids, so sometimes it can happen, but that is very easily detectable. You just make her head up and, your hypotension, she again develops hypotension. You make her head low, then that responds fast. So you just give her fluids fast and things will settle. Of course, it's not only fluid and electrolyte balance. Yes.
Yeah.
Yes.
और मैम for there was extension of the incision. So after there can be bleeding.
I've said it.
It was repaired.
Uneventful. There is no bleeding, etc. The
ठीक है.
only message from this case is you have to go for what is called as universal screening for hypoglycemia in pregnancy. This simple test, not the prick, but the OGCT, 75 grams, single step, OGCT. This simple test can avoid all these complications. Of course, reduce the mortality, morbidity, not only maternal but perinatal also. So I just give you the take-home message that every obstetric unit and every person of the obstetric team must be trained and skilled to manage the maternal collapse. See, your patient has collapsed or your patient has pulseless, you cannot refer this patient to anybody else. The patient can die on the way, right? So you have to manage this patient then and there only. You can call all your colleagues, right? And that's the very reason every team member is expected to be trained and skilled to manage maternal collapse. There's no time for immediate referral. And of course, referred in unsettled condition may worsen the situation. You may lose the patient. So the team, you should not have only the hi-fi setups, the obstetric HDU, ICU, but you yourself and your team should be, well trained. You should basically have a multidisciplinary approach, not only the HDU. That is what the message is. With this, I thank everybody. And I just make an humble appeal to all of you that myself, Dr. Sneha Buyar, all of you know me as Foxy Breast Committee Chairperson and Governing Council Member ICOG, and of course now as AMOGS Chairperson for Emergency Obstetrics Committee. Friends, I am a simple practitioner like majority of you, almost now 32 years of my experience, and I have continued my passion for academics and knowledge sharing, and I'm here in front of you contesting for this post of Foxy Vice President from the West Zone. And I request your votes, not only votes, your wholehearted support, so that I can go ahead and serve you people, Foxians, and serve the organization. So thank you so much, and of course, thank you all of you for such a major contribution to this. I would say the panel discussion. Your experience and evidence has added value to this. So I thank the UPCOG and AMOGS office bearers, and I thank all of you for being here and having me.
Thank you so much, ma'am, for the excellent discussion.
Thank you, ma'am.
Thank you,
ma'am.
each and every one of you. Special thank you to each one of the president, secretaries, panelists for being so cooperative. And congratulations, Sneha ma'am, for one more successful academic feather in your cap. And hope we all keep meeting and learning. Thank you. And thank you, Dr. Anita, also to joining us. And thank you, both of our guest lecturers. Thank you. Thank you so much.
I just make an announcement here that for other zones you have East Zone and South Zone. They are unopposed. You don't have to vote for the South Zone, and there are 4 zones for India. So East Zone and South Zone, they are unopposed, elected. You have to vote for North Zone and West Zone. So your candidate from North Zone. For West Zone, we have 3 candidates, but you have 2 posts. Okay. So please make sure that you make me as your first choice, and then you can vote for the other person, whosoever you feel, because unless you vote for 2 people, it will not be submitted. Okay. So please.
Yahi hai right choice, baby. Aha. Madam, best wishes. And please bless me also as chairperson, Environmental Health Committee. Thank you everyone for joining. It was a pleasure, Sneha ma'am, as ever. Every time I heard this panel, it is wonderful,
Yeah,
and all the panelists were brilliant. Your inputs were great. Thank you, Deepa ma'am. Thank you for staying back.
Thank you so much.
Thank you,
Thank you, ma'am. Deepa ma'am.
Thank you.
I can see Anju Agarwal ma'am's place, Anuradha Khanna ma'am. So all of you, thank you, all our seniors, to please keep guiding us and blessing us. Best of luck, Sneha ma'am and Anita ma'am.
Thank you, Dr. Bharati Maheshwari. Thank you, Anita and Nutan. And thank you so much, Sahiti, for the flawless conduction of this program without any technical glitch. Thank you so much.
Okay,
Congratulations.